Very good evening, doctors. We are live now. So I welcome to all the faculties and the delegates from the behalf of Corona Remedies to the Foxy ICOG CME on 7H in association with UP societies of Lucknow, Kanpur, Agra, Prayagraj, Gorakhpur, Moradabad, Bareilly and Mathura Society to the Core Connect Live, a educational webinar series organized by the doctors. So, first of all, let us start our webinar with Ganesh Vandana with the prayers.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति।
I would like to welcome our conveyors and co-conveyor of today's session, Dr. Kanchan Prasad, who is an ICOG Governing Counseling member, and Dr. Saroj Singh, who is also an ICOG Governing member. Let me introduce Dr. Kanchan Prasad, who is a North Zone Coordinator of Foxy International Academy Exchange Committee of
Thank
2020.
you so much, Prerak. And I think,
And also, I would
yeah. Thank you.
like to welcome Dr. Saroj Singh also,
Thank
who
you,
is a
thank you.
professor in the department.
Okay, thank you so much. So, good evening, everyone. I, Dr. Kanchan Prasad, ICOG Governing Council member and convener for today's program. Welcome you all for ICOG 7, Foxy ICOG 7 CME with UP societies Lucknow, Kanpur, Gorakhpur, Agra, Mathura, Moradabad, Bareilly and Allahabad society. Today we will be discussing about anemia in pregnancy, hypertensive disorder in pregnancy, obesity and PPH, major causes of maternal morbidity and mortality. We are blessed to have our chief guest, Dr. Bhaskar Pal sir and Dr. Sheila Mane ma'am as chief guest and Dr. Naren Malhotra sir, Dr. Sadhana Gupta ma'am, Dr. Preeti Kumar ma'am and Dr. Kiran Pandey ma'am as guest of honor. And our special guest today, Dr. Pratik Tambe sir. Our chief guest, Foxy President, Dr. Bhaskar Pal sir is busy somewhere. He will be joining soon. And so now I take this privilege to invite and welcome Dr. Sheila Mane ma'am, our dynamic, learned and academician par excellence chairperson ICOG as chief guest. Ma'am, we welcome you. Please say some encouraging words. Sheila ma'am.
Yeah, thank you. Stop the CV slide, I think. We know each other, and I must say that congratulate Dr. Kanchan and Dr. Saroj Singh for amalgamation of so many UP societies. And I can say with proud that I have visited all the societies. And I'm really feeling very nice again that I am seeing the president secretary of all these societies again here. And it's a big task to call everybody and arrange everything. And I must thank all the societies, president and secretaries for accepting the invitation to participate in this 7H. I call it 7H. I think already you people have included 4H. Apart from that, also we have 3H, that is hyperglycemia, I think HIV, AIDS and hormones. I think we can do that once again. But today, the four important topics which are covered, as all of us we know, the hypertension, hemorrhage, anemia, and hypertension, as well as the obesity. So these are very important, we know, in the day-to-day practice. And I would like to thank the speakers, Dr. Anupama Upadhyay, Dr. Sikha Seth, Dr. Kanchan Sharma, and for the panel, I would like to thank Dr. Kanchan and all the panelists. Okay, I can see so many names here and I know all of them, and it's nice to see everybody. So once again, I welcome you all for this 7H CME and wishing you all the best for this, and always wish to do academics together, learn together, and learning always continues. So thank you. And I thank all the seniors, Narendra Malhotra, as well as the seniors who have accepted to be the today guest of honor. Dr. Sadhana Gupta, who is our Vice Chair, as well as Dr. Preeti and Dr. Narendra Malhotra and Dr. Kiran Pandey. And thank you. And we can proceed now, Kanchan. Yeah.
Thank you. Thank you so much, ma'am. And now I request co-convener Saroj Singh ma'am to kindly introduce our guest of honor.
Okay, thank you. I thank Dr. Sheila Mane ma'am for being here to bless the occasion. Ma'am, your enthusiasm and dedication for ICOG and for all the academic purposes always encourage all of us to work harder and harder. Thank you for being here. I now invite our guest of honor, Dr. Sadhana Gupta, Vice Chairperson of ICOG, energetic introduction. अरे क्यों भाई, तुम्हें इंट्रोड्यूस करना is a pleasure for me. We are really blessed to have you with us. Say a few words for other regarding.
So, आप इसको कंचन इसे सीवी हटवा दो जरा,
प्रेरक जी सीवी प्लीज
सीवी को प्लेस कर दीजिए. So, all 7H and all UP societies are there, and that is an initiative Dr. Sheila Mane, because anemia, hemorrhage, hypertension, ये जो trio है, that creates always issue in day-to-day practice as well as they present as emergency. And for UP, actually, the things are really urgent and challenging, because somehow in recent survey, it has been found that the UP's maternal mortality rate has increased. So this is something very challenging, and we have to take it as a very urgent issue, and we need to work together. Many, like a few administrative meeting has been placed. Few NGO have come in last 1 month to my place that what we can do, because it is that urgent. We have all the leadership from Uttar Pradesh. Dr. Saroj Singh herself, a dedicated career in teaching at the medical college, and she is working very hard for in the public health institution for the maternal health. And all the leaders, all the president, secretary of OB-GYN Society of UP have great work to do, very hard work to do, and very realistic work to do. That work has to be translated into our day-to-day clinical practice, in our referral protocols, in our the upgrading of the or the making of the HDU and obstetric ICU. So hearty congratulations, Kanchan, because that takes a lot of effort. We know as an organizer that to collect so many societies, so many speakers, and so many office bearer at one platform is not easy. So very hardworking. You were just there on the Halwani ICOG CME also. So Dr. Sheila, your team is always on the go, and you have a dedicated, really wonderful ICOG governing council members, and that speaks a lot about
Very true.
all ICOG members, and this is something great. And hope we all will be there together on 21st, 22nd August in Bengaluru for the dedicated ICOG CME conference. So thank you, Kanchan. And thank you, Sarojji. जो नहीं जानते, Sarojji has been my immediate senior, इसलिए that's why I say that I am too junior for her. And thank you, Sarojji, for all the guidance and the support in the life. Thank you.
Thank you so much, Sadhana, for seeing you rising very high. And we all promise that we all together, all the president, secretary, and all the team which is here, will work together to prevent the preventable, to decrease the maternal mortality in our state, which is quite high, nearly double of what we really want. It's my proud privilege to welcome our past president of FOXY and shining star of Agra, proud of Agra, I should say, Dr. Narendra Malhotra. Dr. Narendra, sir, please. Dr. Narendra, hope you can listen me. He was here. Yes.
Very good evening to all of you. It's indeed a pleasure to be here. Thank you, Dr. Saroj, for the kind words of introduction. Today, we see that education has been brought to the rooms, and that is what is needed. The doors of knowledge can never be closed, and people who cannot travel out to bigger cities for conferences. This is the way to reach to them. And reaching out is very, very important, especially with diseases like anemia, hypertensive disorders, PIH, and mainly obesity. Anemia, we've been trying to battle and make India anemia free since a very, very long time, and that efforts will always continue. Though it is very difficult to eradicate anemia, but at least we should be able to do 10 by 10, 24/7 anemia, anemia bhagao, nana anemia. All those slogans Foxy has been repeatedly giving for anemia. The two P's which are very important, the pregnancy induced hypertension and the PPH. The AOFOG, the Asia Oceania gave 5 P's as the problems of the great obstetrical syndrome. And these two have to be addressed very, very, very closely and to protocols to be followed so that we can save women. We have done a remarkable work on bringing down the maternal mortality to below 90 from 300s or 400s, which we used to talk about in our terms. Lastly, obesity. Now, when we say obesity, usually it is taken, and when we tell a woman you are looking fat, it is taken as body shaming. Now, obesity, we have to remember that is a root cause of many, many diseases. And calling an obese and making her aware that obesity can lead to a lot of problems, I think should be taken away from body shaming. So it is a complex um, problem which has to be dealt. And of course, lifestyle is what has been spoiled because obesity is going to lead to a lot of problems in women. So congratulations to all the Foxy societies of North India, UP, and to ICOG for supporting such CMEs and webinars regularly. I wish you all the best, and I'm there to listen to all the speakers and the panel discussions to catch some key points which might come out of this discussions. All the best to all of you. Enjoy this webinar.
Thank you so much, Dr. Narendra, for being here and to bless the occasion.
Thank you, Dr.
It's-
Narendra.
I now invite Dr. Professor Preeti Kumar, Vice President of North Zone Foxy, a very charming, energetic academician. Dr. Preeti, we are here to listen to what's your dedication for the paramedical staff training. It's everyone know about that.
Thank you so
we are
much.
here to listen few words from you, Dr. Preeti.
Thank you so much, Dr. Saroj. Let me first thank Dr. Sheila Mane and Dr. Pratik Tambe, the ICOG team, for giving me this opportunity. And the second thanks to you and Kanchan for making me part of this program. I think a lot has been mentioned by Dr. Sadhna and Dr. Naren sir. What I really want to tell you is that we have been observing that Dr. Sheila Mane has put her heart and soul in teaching about the PPH and managing PPH. But still, we did a survey recently with CEFOG, and you will not believe 1,500 participants participated in that survey on PPH. And surprisingly, still what we found is the knowledge is there, attitude is there, but the practices are not there. So what we need to refine is through these webinars, we do impart certain knowledge, we do improve the attitude, but how to reform the practices, that is also equally very important.
Very
So
important.
that paper has come out very well. Probably it will be published in maybe AOFOG, or we will be sending to some of the important journals. And the data is also analyzed very beautifully. And I'll share this with Dr. Sheila Mane because this is her area of interest. And the second thing is that I want to tell you is that Dr. Sheila has requested me long time back to have certain webinars with the government for the public health facility staff. But unfortunately, due to some of my problems, I could not do that. But probably we should target that through the government maximum number, because these webinars keep on happening among Foxy. Either ICOG does it, or Foxy does it, or ISOPOP does it, but lot needs to be done for the public sector, and
Very
lot
true.
of nurses need to be involved in that. So our perspective should change actually. So what we can do is, I think Sarojji is the best person. Sadhna ji had been doing our groundwork so much. She has done. I've learned a lot from her. But UP state has formed a state transformation commission to reduce the maternal mortality. We are working with them, they are approaching us. But probably we need to do not only with the UP state, but other states also. ICOG should try to collaborate and do. I think MP they have already done, but a lot other states need to be covered. And we try to help ICOG with such a dynamic leadership of Dr. Sheila Mane, Dr. Pratik Tambe, and incoming chairs, Vice Chair Dr. Sadhna Gupta. So all support to ICOG wherever possible, and I'm happy to know that all these topics are being covered today. Very important, very relevant, related to maternal and women's health. But what I said is that knowledge attitudes need to be transformed into practices. That's very, very important. So thank you so much. All the best. And thank you for all the faculty who have joined and spared their time for today's webinar. And I'm here to listen to all the deliberations today. Thank you
Well
so much,
said.
Sheila
Yeah.
ji, once again.
Well
Thank you,
said. Well
Kanchan,
said.
and thank you, Saroji.
Thank you so much, Dr. Priti. You very rightly said that skill development and utilization of that skill is also very important. And in public sector also a lot of training programs are going on, which many of us them we have also conducted. But even then its utilization at the time when it is required, that is the most important thing which has to be done. Thank you so much for being with us.
So,
I
Sarojji,
now,
what happened is in public facility, many of the time the staff keeps on rotating. What we found in CSCs and other district hospitals, the nursing staff gets changed to the other department. So
yes.
again, you have to retrain them. So that's the biggest issue in the public sector.
प्रीति जी
So
पेरेंटल
this is
आया
what we
उनको हाथ
found.
से
Thank you so much.
लगवाया अपने सामने बैठ बैठ के भी लगवाया बहुत बार बट मेनी टाइम्स खींच रहते
हाँ
हैं कुछ चीजें रहती हैं दैट ऑल थिंग्स वी हैव टू लुक फॉर
जी thank you
थैंक
so
यू
much,
सो
Sarojji. Thank you.
I now invite our UPCOG president, my dear friend Dr. Kiran Pandey, to bless with her few words of blessing. She has been the chairperson of Medical Education Committee for 3 years. We have seen her working very hardly. Dr.
I
Kiran,
think
please.
currently she is the president of UPCOG and all societies are
Ah.
under UP
UP
president. Yeah.
UPCOG. That's why I
UP,
said
UP
Kiran.
society.
Dr. Kiran?
Ma'am, unmute you
Ah.
yourself. Kiran ma'am, you are muted.
Tell the technical people to unmute her.
Mr. Prerak, please unmute her.
Now, am I audible?
Yes,
ma'am.
yes.
Okay,
After
okay.
mute.
अच्छा
अब ठीक है
ओके अब अभी ठीक है
हाँ
Yes,
हाँ
ma'am.
ठीक है
Okay, okay. Thank you very much, Dr. Sarwood, for very kind words. Respected chief guest and Dr. Dr. Sheila Mane, ICOG chairperson, Dr. Sadhna, Dr. Pratik, even Dr. Ashok Kumar, although they are not here, but still they are part of ICOG and taking care of all the programs. My dear friend Saroj, and I'm really privileged to share the dais with Dr. Preeti. She is the vice president, and so many dignitaries. Dr. Narendra, who is the we know past president of many many organizations and is working hard for all the program incentives into the UP. So it's really very important. The topic which has been the topics actually which have been selected by the Muradabad team, Dr. Kanchan. She is very keen and very enthusiastic for this. All of them are very important. Maybe it anemia, maybe it is hypertension, maybe it is obesity and PPH. All are the very, very important causes of maternal mortality. As it is we all know that the maternal mortality with the efforts of government and Foxy and ICOG have reduced to a great degree, but still it has to come to a lot more has to be done to further reduce it. So the topic selections is very good. Even as UPCOG president, I have requested everyone to take programs for Anemia Mukt Bharat, maybe awareness, maybe teaching, maybe practically supporting the anemia, whatever ways. So all they actually needs, I know the Preeti was saying that the awareness has all been created by many webinars, and but the practical implications is not that. But the thing is, we can't say practical implications are also there. That is why we could reduce the maternal mortality from 300 to such a low, less than 90. But it's a slow process. Definitely, it's a slow process. It need to be done more and more awareness at very grassroots at the in the smaller cities and the smaller places have to be done. Many factors are there. Not only the our efforts. It's the our women are themselves and the families are not so much still educated for that, and they take the pregnancy as it is natural कि ये तो हमेशा से होती है, ऐसी कोई नई बात नहीं है, and they don't take those medicines or whatever that multiple reasons are not there. I'm not to discuss them. Of course they will be told by the learned speakers. So all the topics are very good. Dr. Sheila Mane has been, I mean, the PPH and Dr. Sheila Mane are synonymous. Whenever you talk, I know practically how passionate she is. Practically, she used to demonstrate all the management and everything. So very congratulations to Muradabad team, all the delegates who are participating, the ICOG, and of course, which we are a part of Foxy. So this very important webinar. Unfortunately, I'll try to be there, but developed viral fever today, so I'm little uh, up, little having little dizzy or all that. But I'll try to be there as much as possible and join it. So once again, I will congratulate all of the stakeholders of this webinar, and definitely if we together keep on working as a team, not if not today, tomorrow or any day, finally definitely we will be able to cure these things, or at least reach to a satisfactory level of maternal mortality. I'm sure for this. Paramedics are definitely very important. Even in certain ways, they are more important. They are more close to the patient. They are more tuned. They have to deal with these issues very sensitively. So we should sensitize them also to the degree of this. So thank you, Dr. Kanchan, for involving me and giving me this honor to share the dice with so many of the legendary figures of the Foxy and ICOG. Thank you very much. We'll try to do at the level of UPCOG also whatever we can do maximum. Thank you.
Thank you,
Thank you
Dr.
so
Kiran.
much.
Yeah.
Thank you so much, Dr. Kiran, and get well soon.
हाँ yes, वो थोड़ा वायरल आजकल चला हुआ है.
I now invite our special guest, our dedicated, hardworking, silently, Dr. Pratik Tambe, to say a few words because he is the one who is working very hard with Dr. Sheila Mane ma'am for taking ICOG to greater heights. Dr. Pratik, please.
Good evening, everybody. It's always a pleasure and a privilege to be in one of the 7H CMEs. As I'm so fond of saying, Dr. Sheila Mane has had fantastic insights and she has amazing vision. And she started this series just a couple of months ago. We've done so many of these programs all over the country. And at the end of every program, the audience feedback is so amazing. All the president secretaries who come together, they give wonderful feedback. They're very happy that this program is being conducted. And it tackles the seven major important issues in women's health today. It's not only in reproductive health, it's not only in obstetrics, but in general, these are women's health issues which need to be tackled, which need to be addressed, and this needs to be disseminated into the lay people as well. So today we have four topics which are being addressed, and hopefully we can have another program. And Kanchan and Dr. Saroj will take the initiative and take care of the remaining three as well. Maybe after a month or two, once we've done with the ICOG annual conference, which is in Bangalore, 22nd and 23rd of August. My gratitude to all the societies who have joined today, all the office bearers. Very happy to see Dr. Meera Laktakia, Dr. Ritika Agarwal, Dr. Kanchan Sharma, Sonam Rastogi, Upma Jaiswal, Anita Nath. All of these are my friends. I have met them so many times in so many different occasions. Look forward to working more closely with all of you very soon in the near future. And if you've not registered for the ICOG annual conference, please register ASAP. I want to see all of you there. I want to see huge participation and representation from your societies as well. Make as many fellows as possible because this is how, once the academics and the knowledge percolates to the ordinary OBGYN, that is how we will be able to impact women's healthcare to the maximum. That is actually the purpose of this organization, ICOG, setting the benchmark in OBGYN excellence. So please spread the word, get as many fellows as possible. If it's late for you to apply now, you can still apply later and receive your fellowship at Surat in January of 2027. My best wishes to all of you always. Anything you require from me, give me a call, message me. I'm always there for you. Thank you again, and I wish this program all the very best.
Thank you so much, Dr. Pratik, for your encouraging words. I hand over the mic to Dr. Kanchan now. Dr. Kanchan?
Yes, ma'am. Thank you, ma'am. And thank you, Pratik sir, for all those kind words. And now I hand over the academic session, scientific session to our two master of ceremony, Dr. Upma Yadav Jaiswal, Secretary Gorakhpur, and Dr. Vartika Kishore, past President, Mathura Ops and Gynae Society.
Thank you, Dr. Kanchan. Good evening, everyone. I am Dr. Upma Jaiswal from Gorakhpur, and I'm very thankful to Dr. Pratik Tambe sir and Dr. Sheila Mane ma'am for giving me this opportunity, and my dear friend Dr. Kanchan Prasad just called me 3-4 days ago, and she relieved me actually, and I was very, very thankful to her for this. And as rightly said, ICOG is the academic wing of FOXY, which has always excelled in creating a strong academic foundation for practicing obs and gynae of our country, and it continues to strengthen our fraternity and inspires us also to keep updating our knowledge because it is very important for the benefit of our patients, the women we serve, as rightly said by Dr. Sir. It has really raised the standard of India in the academics of our country, and it has come at par with very international level also these days. So now we begin our scientific deliberation with a topic that continues to be one of the greatest contributors to maternal morbidity and mortality in our country. For this, the session 1, which is on a contemporary approach to anemia and pregnancy, the hemoglobin saga. To guide the scientific session.
Dr. Upma, your voice is a bit low. I think some problem is with your mic or something.
Oh my God.
You can just come a little closer to the screen, then it will be better.
Oh my God.
Yeah,
Wasn't that
fine.
heard?
Yeah, it's okay now. It's
Okay,
fine.
okay. To begin the scientific deliberation, there is a topic. It continues to be one of the greatest contributors to maternal mortality and morbidity of our country. And for the first session, which is on contemporary approach to anemia and pregnancy, the hemoglobin saga. To guide this scientific session, I have the privilege of inviting our esteemed chairpersons, Dr. Rajni Pachori ma'am. She is the director at Ravi Hospital, Agra, and at present she is vice president of Agra OBG Society, and she has conducted numerous laparoscopic workshops and UPCOG workshops at her center. And she was vice president Agra Obs and Gynae Society. Her hospital is DNB accredited center. And next chairperson is Dr. Ritika Agrawal. She is an alumni of Bharati Vidyapeeth Medical College, Pune, and she has done a fellowship in FRM from D.Y. Patil College. And she's a professor at Venkateshwar Institute of Medical Sciences, and currently she's president Muradabad Obs and Gynae Society. Our next chairperson is Dr. Latika Agrawal. She's an alumni of Jhansi Medical College, and she has done a residency from UCMS New Delhi, founder and director of Sarthak IVF
hospital at Bareilly, and she's was the founder of the first IVF center at Rohilkhand area. And she was vice president UPSR, and at present she is president Bareilly Obs-and-Gynae Society. So welcome, ma'am. We should start our next session, and please with our speaker, Dr. Anupama Upadhyay, ma'am, and she's associate professor at MLN Medical College. The chairpersons, please introduce, ma'am. Dr. Latika, ma'am.
In case they're not there, you can go ahead in the interest of time. It's already 6:30.
I'm there. Hasn't
Dr.
joined.
Anupam.
I called her, but she's not picking the phone. She hasn't joined.
Dr. Ritika can do the needful.
Dr.
Yes,
Ritika,
yes,
please
yes.
you introduce, ma'am.
So Dr. Anupama Upadhyay, ma'am, she is MS, MRCOG, FICOG. She's the Associate Professor of Obs and Gynae at Prayagraj Medical College. Her areas of interest are high-risk pregnancy and urogynecology. She has attended several state and national conferences as a faculty. She's published many in state and national newspapers. She's a master trainer for comprehensive abortion care and RRTC and CEONNC. She's trained in hysteroscopy, advanced laparoscopy, and she's a member of FOXY. She's a life member of UPCOG and ISOPAR.
Thank you so much, ma'am, for your kind words. Can I share the screen now?
Please go ahead now.
Is my screen visible and am I audible
Yeah,
properly?
you can go full screen. Yeah, you're audible. You can go full screen now.
A very good evening to all of you. And I'm really blessed today, and I want to extend my heartfelt gratitude to all the Mahagurus who have
Dr.
given me.
Anupam,
Yes.
full screen.
अनु स्लाइड शेयर कर लीजिए स्लाइड शेयर कर लीजिए
Slide share किया है मैम full screen किया है
अब आ गया
Yes, it is there now.
Ma'am, is it visible now? Okay.
Yes.
So a very good evening to all, and I also want to extend my heartfelt gratitude to all the Mahagurus, Bhaskar sir, Sheila Mane ma'am, Pratik Tambe sir, and it won't be possible to take all the names who have blessed me today with an opportunity on such an prestigious platform. So let's quickly start with my topic, contemporary approach to anemia in pregnancy, the hemoglobin saga. Excuse me, the slide is not moving. Suppose now. Okay. So maternal mortality ratio in India has declined tremendously to 88 per lakh live births. Few states like Kerala, Tamil Nadu are already below the SDG, while states like Uttar Pradesh, where the MMR is 141, still stay above national average. Our sustainable development goal is below 70 per lakh live births by 2030. In this figure, we can see the global prevalence of anemia in pregnancy, which is 20 to 60%. And here are the states which are performing high. According to NFHS 5 statistics, the pregnancy in anemia in pregnancy has risen to 52.2% as compared to statistics from NFHS 4, which is alarming. If we see the state-wise performance, we have definitely performed better, but still the statistics remain high. We all are aware of the complications of anemia, starting from antepartum, resulting into preterm labor, preeclampsia, intercurrent infections, intrauterine death, antepartum hemorrhage, intrapartum, prolonged labor, increased rate of operative delivery, fetal distress, abruption, postpartum causing postpartum hemorrhage, puerperal sepsis, lactation failure, subinvolution of uterus, postpartum depression, also causing increased perinatal morbidity and mortality resulting from low birth weight, prematurity, neonatal sepsis, neonatal anemia, and abnormal cognitive development. So, since we are talking about maternal mortality, we should know that why anemia causes PPH. So, anemia increases the heart rate and cardiac output, thus increasing the blood loss. Also, due to reduced blood viscosity, anemia also disrupts the lamellar flow. That is, it prevents platelet margination. It is the blood clots in anemic women are more susceptible to fibrinolysis, and iron deficiency also causes uterine atony. We know that iron is a very important molecule for physiological and functioning of every cell and organ in the body. like oxygen transport, erythropoiesis, energy production, DNA synthesis, cell proliferation, and growth. So now coming how we have defined anemia, that it is a decrease in oxygen carrying capacity of blood due to decrease in hemoglobin concentration or dead cell mass. Historically, a hemoglobin value that is less than 2 standard deviation below the median value for healthy matched population by age, sex, altitude, smoking, and pregnancy status. So WHO cutoff is hemoglobin less than 11 gram per dl. Also, it aligns with the cutoff given by Ministry of Health and Family Welfare, ICMR, FIGO 2025, and Anemia Mukt Bharat 2026. While CDC gives trimester-wise cutoff as 11 gram per dl in first and second trimester and 10.5 gram per dl in second trimester. So we all know these grading of severity of anemia, but ICMR still retains the fourth grade, that is very severe anemia when hemoglobin is less than 4 gram per dl. So this is well-known fact that in pregnancy, blood volume and plasma volume expands by 40 to 45%, while red cell mass increases only up to the extent of 18 to 20%, thus causing hemodilution and physiological anemia. So why iron deficiency anemia will dominate in pregnancy? So iron requirement in pregnancy is 1300 milligram for expansion of fetus placenta and also for lactation requirement. But since there is sparing of 300 milligram of iron due to amenorrhea, the net requirement is 1000 milligram. Recommended allowance of iron increases in first trimester 0.8 mg per day, to third trimester it is 6 to 7 milligram per day, and only 10% iron is absorbed from the diet, whereas there is daily loss of 1.5 milligram per day of iron. So pregnant women are uniquely vulnerable. Pre-pregnancy iron stores are already low, poor bioavailability of dietary iron, GI absorption cannot keep pace with the increased demand, also short inter-pregnancy intervals, and there could also be concurrent blood losses. So we are well aware of all these symptoms and signs, as mild anemia women can present, maybe asymptomatic, but women can present with features like fatigue, exhaustion, muscle weakness, and skin, hair, and nail changes. Pica is an desire for eating non-edible substances like clay, mud, ice, paper. So we check for pallor, also tachycardia, tachypnea, edema, and we do a central a cardiovascular system examination where we can find murmur or basal crepitations in severe cases. So the diagnostic tests which are applied and the iron deficiency anemia cutoff are as follows. The mean corpuscular volume is less than 80 femtoliter. Then red cell distribution width should be more than 14%. Ferritin is less than 30 microgram per liter. Total iron binding capacity is more than 360 microgram per dl. Serum iron is less than 50 microgram per dl. Transferrin saturation is less than 20%. We all very well know this appearance of the peripheral smeared slide in iron deficiency anemia, showing poikilocytosis, anisocytosis, microcytosis, hypochromia. So serum ferritin is the best test for diagnosis of iron deficiency in absence of inflammation. But as we know that serum ferritin is also an acute phase reactant and is raised in acute and chronic inflammatory conditions. So whenever there is inflammatory disorder also, transferrin saturation of less than 20% is required to confirm iron deficiency. According to literature, in resource-constrained setting, we can employ a combination of low MCV and high RDW sufficient enough to start treatment for iron deficiency anemia. So we can see the different presentations according to laboratory parameters. So iron deficiency, the MCV will be low. In thalassemia trait, it will be out of proportion to hemoglobin and very low. Anemia of chronic disease, it remains maybe remain normal or sometimes towards lower side. B12 folate deficiency, it is always high, more than 100 femtoliter. RDW is high in iron deficiency anemia and folate B12, while it is normal in thalassemia and anemia of chronic disease. Serum ferritin is low in iron deficiency anemia and rest it remains normal. It could be high in thalassemia trait or anemia of chronic disease. Menzer index is used to differentiate iron deficiency anemia and thalassemia trait. It is MCV upon RBC count. If a value is more than 30, it is suggestive of iron deficiency anemia. So we employ specific test for the diagnosis then. Iron deficiency without anemia is a new concept where hemoglobin can be normal, but the iron availability is insufficient to meet the body's needs. According to Harrison's textbook of internal medicine, there are 3 stages of iron deficiency anemia. First is depletion of stores, second is iron deficient erythropoiesis, and third is frank iron deficiency anemia. And we can see that only a single parameter, that is serum ferritin, is altered with the depletion of store. Rest all parameters are normal, which will be deranged only in frank iron deficiency anemia. So our vision now is to catch women in this stage. Management will include treatment of the underlying cause, dietary interventions, and iron supplementation. So if we have to break this cycle, we have to prevent anemia prior to pregnancy, detect early in pregnancy and start treatment early second trimester, and check again in 20 weeks and correct it. So on a global level, food-based approaches such as iron-rich foods, legumes, green leafy vegetables, or meat are recommended by WHO. We also encourage the enhancers of absorption, protein, meat, ascorbic acid, and to avoid inhibitors of iron absorption like phytates, calcium, tannins, etc. So we have different class of iron salts, and we know that ferrous salts are well absorbed than ferric salts. So there could be organic salt like ferric polymaltose, elemental salts, chelated iron. But in various studies, the ferrous ascorbate has shown to perform better in terms of bioavailability and tolerance. So what are the challenges of oral iron? Compliance. The women should be educated very properly that it is why it is required to continue the supplement throughout pregnancy and even postpartum. She has to be educated regarding GI side effects such as nausea, epigastric discomfort, and constipation. And despite that, if she is intolerant, we can try a lower dose, single daily dosing, and also we can switch preparation before making hasty decision for parenteral iron. Method of administration should also be properly taught to the women that iron should not be taken with calcium together, or it should not be taken with tea, coffee, and there should be at least 1 hour gap between the meal if it is taken before meals, or at least 2 hours after meals. Role of hepcidin is very important in iron regulation. So it is a hepatic peptide hormone that controls intestinal iron absorption and also distribution of iron from body stores. Increasing iron level in plasma increases hepcidin, which blocks iron absorption from the diet and its further storage. So whenever there is low iron, the hepcidin is blocked and ferroportin mediated absorption of iron is increased, while whenever there is high iron, the hepcidin production is increased and ferroportin mediated iron absorption is blocked. Hepcidin is lower during pregnancy to ensure greater iron bioavailability to the mother and fetus. So considering the hepcidin effect, it has been proposed that iron supplement on alternate days in single doses optimizes iron absorption, and this could be a preferable regimen. These are the famous ferrous salts which are available and their elemental iron content. We see that now newer oral iron formulations have a lower content. So GI tolerance is good. So how is oral iron dosing prescribed? According to Anemia Mukt Bharat Abhiyan, 2 iron folic acid tablets per day, 120 mg elemental iron for therapeutic correction is to be taken on an empty stomach with vitamin C source. The absorption of oral iron increases with increasing doses only up to 160 milligram per day. Increasing the dose beyond the recommended range increases gastrointestinal side effects without improving efficacy. According to WHO 2024, daily oral iron and folic acid supplementation with 30 to 60 milligram of elemental iron and 400 microgram of folic acid is recommended for pregnant women. The equivalent of 60 mg of elemental iron is 300 mg ferrous sulfate heptahydrate. According to Anemia Mukt Bharat, updated in 2026, pregnant women receive 1 red iron and folic acid tablet daily, starting from 4th month through the rest of pregnancy for a minimum of 180 days, plus another 180 days postpartum. Each red tablet contains 60 milligram of elemental iron and 500 microgram of folic acid. Multiple micronutrient supplementation is now proposed by WHO for low, middle, and middle income countries to be started 2 to 3 months before conception to prevent neural tube defects, and weekly multiple micronutrient supplementation is not recommended. So WHO has recommended following 15 micronutrients with their dosages apart from folic acid and iron, copper, iodine, selenium, vitamin A, B1, B2, B3, B6, and B12, vitamin C, vitamin D, vitamin E, and zinc. Why parenteral iron now? Because earlier preparations were not safe. They had more side effects. Now safer and single dose preparations are available. Indications for parenteral iron in pregnancy are moderate to severe anemia, 13 to 34 weeks of gestation, or even in postpartum women, whenever oral iron is not tolerated, non-compliant, or improvement is less than 1 gram per DL after 1 month. When is parenteral iron contraindicated? If anemia is not due to iron deficiency, known hypersensitivity to iron sucrose, liver disease, hemolytic anemia, fever, or acute infection at the time of infusion. We calculate the total iron requirement with the Ganzoni formula. And for stores, we add 500 if the weight is more than 35 kg. If the weight is less than 35 kg, we calculate with 15 mg per kg body weight. So IV iron preparations available in India are iron sucrose, ferric carboxymaltose, FCM, and ferric derissomaltose or iron isomaltoside. Single dose formulations are FCM and iron isomaltoside. Why IV iron works? Because IV iron immediately saturates the circulating transferrin and overcomes the hepcidin block. IV iron has a central iron core with a carbohydrate shell which stabilizes the molecule, and there is a slow release of elemental iron. Comparing the parenteral iron options, single dose is that can be given iron sucrose 200 mg, FCM 1000 mg, and isomaltoside 1000 to 2000 mg. Maximum per pregnancy can be given up to 1000 mg, 1500 mg. Total dose repletion is possible, but we have very limited pregnancy outcome data. So nothing can be said in a very confident manner. Still, much studies are required to bring it to practice. Infusion time is 20 to 30 minutes, FCM 15 minutes, ferric derissomaltose 20 to 30 minutes. Visits needed up to 5, 1 to 2, often 1. Antigenicity for FCM is much lower and half-life is much higher. Key caution with iron sucrose is that test dose is historically used and multiple visits are required. FCM, there is transient hypophosphatemia, but here I would like to emphasize that literature suggests that there is no hypophosphatemia with single dose FCM transfusion. Only the patients with inflammatory bowel disease or chronic kidney disease or who repeatedly require FCM transfusion, we have to worry for this hypophosphatemia side effects. So advantages of parenteral iron over oral iron is many: safe and cost effective, quick response of repletion of iron stores, absence of GI side effects. Then it is superior for superior blood loss cases, like in heavy menstrual bleeding also, apart from pregnancy, ability to administer larger doses in one visit, and suitable for patients with comorbidities such as inflammatory bowel disease or chronic renal impairment. So there are adverse events, though less frequently encountered. Common are nausea or infusion site reactions. Less common are headache, hypotension, tachycardia, vomiting, dyspnea, and severe could be anaphylactic reactions. So this parenteral iron transfusion should always be supervised. Its administration has to be supervised in a facility where resuscitative equipments are properly available. And if Even at slightest sign of reaction, we have to stop the infusion. We have to monitor the patient for progression of symptoms. And if the patient is stable for 15 minutes, then only we will restart the transfusion at half the infusion rate that we have done, and we will observe the patient for further 2 hours. So, response to therapy. Hemoglobin response less than 1 gram per dl at day 14 of oral iron. Identify subjects with iron deficiency anemia who should be transitioned to IV iron supplementation. This is a Harvard Medical School study which has proposed that we can assess at day 14 response to iron, how the patient is responding, and take decision about further continuation or discontinuation of the therapy. Also, a reassessment should be performed no earlier than 4 to 6 weeks after treatment to allow adequate time for erythropoiesis and avoid interference of IV iron with assays of iron status. So many of the pharma companies, they will claim that hemoglobin rise within 15 days and as early as 15 days. But literature suggests that you have to do a repeat complete blood count at least 4 weeks after the transfusion. Indications of blood transfusion in anemia of pregnancy have decreased to much extent because IV therapy has been highly effective and fewer than 1% of patients will require blood transfusion. If the hemoglobin is less than 5 gram per dl or severe anemia beyond 34 weeks, the patient is hemodynamically unstable or unresponsive to IV iron only in those conditions. And experts underscore the transfusion risks, including transmission of parasites, viral infections, and non-viral fevers. So most providers prefer to avoid where alternative exist. Regarding postpartum anemia, a cutoff of less than 11 gram per dl is considered as anemia in postpartum period according to FIGO 2025. And according to WHO and NATA, postpartum anemia has defined as hemoglobin value of less than 11 gram per dl at 1 week post delivery and less than 12 gram per dl in the first postpartum year. So apart from continuing the prophylaxis 3 to 6 months postpartum, if there is mild to moderate anemia, 2 iron folic acid tablets per day according to Anemia Mukh Bharat. If the anemia is severe or non-responsive, parenteral iron FCM to be given. Oral iron is not given during or following FCM administration for 4 weeks, and iron therapy is compatible with breastfeeding. This study shows that 3 pediatric population are highly susceptible for iron deficiency, that is fetus, newborn, children less than 6 months of age up to 2.5 years, and teenage girls. And early iron deficiency results in neurodevelopmental alterations that persist despite iron repletion. Iron containing enzymes are very important in the brain for myelination and also neurotransmitter synthesis like dopamine, serotonin, norepinephrine. So we have 1,000 days window of opportunity, that is pregnancy, year 1 and year 2. So what are the prevention strategies available? Apart from consuming iron-rich foods, food fortification strategies, and promoting the enhancers of absorption and avoiding the inhibitors of absorption. Soaking and fermentation will reduce the phytate content and improve dietary iron absorption. A context-specific recommendation supports once weekly intermittent oral iron supplementation when daily iron is not acceptable due to gastrointestinal side effects, but it is required first to confirm the absence of anemia. Because if anemia is present, 120 mg elemental iron plus 400 microgram folic acid daily until anemia is corrected. Thereafter, continue with the standard daily regime or switch to the intermittent regime as per tolerability. Also, we will do deworming, 400 mg single dose of albendazole in the second trimester, pair deworming with footwear, hand washing, sanitation, safe food and water, adequate birth spacing, and pre-pregnancy anemia correction.
Anupma ma'am,
This is the,
sorry to interrupt you. Just a request to wind up early.
this is the last slide. This is
Thank you.
last slide.
Thank you, sir.
So the latest updation in Anemia Mukh Bharat strategy is the 7 into 7 into 7 strategy. Now, new beneficiary has been added, new intervention in the form of eating right, that is promotion of diversified iron-rich diets every day, and 7 institutional mechanism, that is digitally integrated monitoring and evaluation framework. So take home message, we all know all this. Just a quick revision that anemia is sign, not a diagnosis. So we have to confirm the cause before treating the number. Current guidelines recommend universal cutoff of 11 gram per DL throughout the antenatal and postpartum period for diagnosis of anemia in pregnancy. Screen anemia, complete blood count at booking and every trimester. Ferritin is the best marker of iron stores, but interpret alongside C-reactive protein. Gestational age drives urgency as much as hemoglobin value. Oral iron remains the first line. Give it a real trial before escalating. FCM offers single visit correction, so it is preferred. And second trimester onwards can be given. Never mix iron sucrose and FCM in the same patient treatment course. Planned delivery, blood availability, and anesthesia in advance for every anemic woman near term. And Anemia Mukt Bharat has shifted the India's approach from prophylaxis to therapeutic trackable case management. So if we want our next generation to be smarter and intelligent, their mothers should not be anemic and not iron deficient. These are my references. Thank you so much, everyone, for listening so patiently and giving me this opportunity.
Thank you, Anupma ma'am. It was wonderful lecture. And now I request chairperson to give concluding remark.
Very good lecture, Dr. Anupma. And as we're working in India, and anemia is one of the main reasons for mortality still in India. So to make Anemia Mukt Bharat, very rightly said that FCM is a very good choice, and now even the prices come down, and even the Foxy is trying really hard with the MRs to get it more down and feasible for everyone. So very well explained, ma'am.
Thank you, ma'am.
Thank you so much. Thank you, speakers. Thank you, chairpersons. Now I give the hand over the session to our MOC, Upma ma'am.
Thank you, Dr. Kanchan. And now moving ahead with the second session on managing hypertension in pregnancy, guard against the silent threat. Chairpersons for this sessions are Dr. Meenal Jain, Secretary, Agra Obs and Gynae Society. May we have the CV? The other chairpersons are Dr. Seema Malhotra, Madam, from Secretary from Kanpur Society, and Dr. Renu Tandon, Ma'am. Dr. Renu Tandon, Ma'am, from Kanpur Society, and Dr. Seema Malhotra, Madam, from Lucknow Society. The speaker for this session is Dr. Shikha Seth, Madam.
Prerna, please display the CV of chairperson and speakers. Okay, Vartika ma'am, go ahead.
Okay. So now I would request Dr. Meenal Jain to please introduce our esteemed speaker, Dr. Shikha Seth, Madam.
Good evening, everybody. I thank ICOG team and especially Dr. Kanchan for giving us, for giving Agra Society to be a part of this very important and informative webinar. And it is always a pleasure to introduce Dr. Shikha Seth, ma'am. She has been my immediate senior in MBBS at SN Medical College. So she is quite dear to me. Presently, she is Professor and Head Department of Obs and Gynae, All India Institute of Medical Sciences, AIIMS, Gorakhpur. And she has also served as HOD at Safai Medical College for many years. She has many achievements to her credit. She has been awarded many prestigious awards, including the Mohinder Kochar Award for paper presentation in AICOG, Best E-Poster Award, Dr. Praveen Mehta Foxy Laparoscopic Fellowship, Shri Prabhu Dayal Baveja Memorial Gold Medal for publication in UP chapter, DC Datta Best Textbook Foxy Award twice, which is really commendable. She has over 60 publications and she is a hardcore researcher and academician. She has been the editor for Foxy Update series. She is assistant editor for the Journal of CEFOG, authored many chapters and reviewer of BMJ case report, and I welcome Dr. Shikha Seth, ma'am.
Thank you very much. First of all, I thank the whole of the team and the respected seniors for giving me the opportunity to speak on this very important section that is hypertension in pregnancy. And thank you, Kanchan, for calling me up for this particular thing, because this is really an important section and I love to work on this. I have some particular researches also going on in my department on this thing. So it's very dear to me. Let me just connect with my screen share. Okay. So are you able to see my screen, the
Yes,
presentation?
ma'am. Yes, ma'am. Slide share, please.
You can go full screen now.
Yeah. So hope I'm clearly audible also. So
Perfect. Yeah, go ahead.
thank you. So let's start with what is hypertension in pregnancy and how this silent disease this goes on and complicates the life in such a manner that it is associated with very high morbidity as well as mortality, not only for the mother but also for the fetus also. Just a minute. Why we are talking about the again this important that prevalence at our end is very high. Normally the prevalence which is globally is around 4 to 5%, but if we talk about the prevalence in India, it ranges between 5 to 10%, and in some of the rural areas or different areas may have shown the prevalence of around 11 to 12% also, and it has impact on the mother in the form of affecting each and every system of the body, as well as impact on the fetus in the form of complications in form of growth retardation, as well as the stillbirth. If we see the causes of stillbirth, the hypertension of pregnancy is the most common complication which is associated with stillbirths in the pregnancy, or even the intrapartum complications in the form of intrapartum deaths because of associated oligohydramnios and the vascular complications that happens to the fetus. Even in not in this pregnancy itself, it has the future consequences also, in the form that these women who have developed preeclampsia or eclampsia, this time they have very high chances to develop ischemic stroke and cardiovascular diseases later in the life and a bit earlier than their normal counterparts. Similarly, the babies of these preeclamptic women also have a high chances or high risk of developing cardiovascular problems in their life also. So some genetic epigenetic changes also takes place in utero, which leads to all these problems, and this leads to, this is all evidence based which is there. So I just start with the terminology which we commonly use with hypertensive disorders of pregnancy, and there is a spectra which goes on. So we just divide into the women who develop the hypertension during the pregnancy, that is new onset hypertension in the pregnancy, and we can come across because of the now the women are getting pregnant later in the life, so we may come across, or we very often come across the women who are already hypertensive and now they become pregnant. So we have one called as pre-existing hypertension or essential hypertension, and then or a chronic hypertension, whatever we call it. And then while having during the pregnancy, this chronic hypertension further becomes much more worsen or complicated with organ dysfunction syndrome. So then we start calling it superimposed preeclampsia. So one is chronic hypertension if we know that the woman is already hypertensive, or in the first trimester we come across a woman with the blood pressure raised. Similarly, the woman who has come to us initially in the first trimester is normotensive, and then later on, after 20th week or 30th week, she develops a raised blood pressure. Then we start calling it gestational hypertension, because it is pregnancy oriented, newly developed hypertension. And if this hypertension is associated with some of or the other end organ damage associated problems, like maybe the associated proteinuria, maybe some visual symptoms, some cerebral symptoms in the form of headache, visual symptoms hematological problems like thrombocytopenia, liver disorders. Then these any of the organ if gets associatedly affected along with the raised blood pressure, then we start saying it the term preeclampsia. So new onset hypertension in pregnancy, that is usually seen after 20th week because of the placental changes, we call it gestational hypertension. When it is associated with some end organ damage signs, then we start calling it preeclampsia. And if the patient develops fits, it's called eclampsia. And we have one more syndrome very commonly we come across in the severe form of hypertension or preeclampsia is HELP syndrome, that is hemolysis, elevated liver enzyme, and low platelet. When this three trio is there, the outcomes have been seen very poor and worse. So we have to be very vigilant about these three things whenever we are monitoring a case of preeclampsia. So gestational hypertension, preeclampsia, and superimposed preeclampsia on a chronic hypertensive patient. These are the spectra which we commonly come across. And it is important to note that in chronic hypertension, just rise in the blood pressure doesn't mean that it is a case of preeclampsia or proteinuria, because chronic hypertensive will always have some renal abnormalities also, and they may be having some proteinuria also even before the pregnancy. So just having a proteinuria or just rise in a blood pressure doesn't mean that is superimposed preeclampsia. It has to be some other signs. If she was non-proteinuric earlier, then a new onset proteinuria definitely will consider as preeclampsia. But if she was proteinuric also, then it means that she has to have some other organ dysfunction in the form of biochemical abnormalities. Then only we will call it a superimposed preeclampsia on chronic hypertension. So going for the defining the hypertension in pregnancy, the cutoff mark usually given is 140 by 90. 140 millimeter of mercury of systolic or 90 millimeter of mercury of diastolic. Both or even a single one is considered as hypertension in pregnancy. And if we talk about the diagnosis of preeclampsia in pregnancy, so preeclampsia has, again, the different societies give somewhat different definitions, but the most commonly which we all follow up in our practice is the definition given by either the ISSHP or the ACOG, which is almost similar, except that in ISSHP, they define uteroplacental dysfunction as a part of diagnostic criteria of preeclampsia, while ACOG does not confine its uteroplacental insufficiency or FGR in its diagnostic criteria. FGR, yani fetal growth restriction, can be there in the fetus, but they consider it as a complication. They don't consider it as a diagnostic criteria of preeclampsia, while the International Society of Hypertension, they define this as one of the criteria. So what can be the organ dysfunction problems? It can be the renal problem, which is most commonly seen is proteinuria. In the form of liver involvement is identified by the liver enzymes, that is SGOT, SGPT, when they become double their normal values. Lung, the patient may have dyspnea, Krebs, or pulmonary edema. Neurological problems may be having the headache, the abnormal mental state, blindness, features of stroke, and hyperreflexia. Hematological problems in the form of low platelet count, abnormal coagulation profile, and the hemolysis. And of course, the last but not the least, related to the fetus, that is placenta, uteroplacental dysfunction, which is we identify with the help of umbilical artery Doppler. So umbilical artery changes which define the severity of the fetal growth restriction. Other sub-classification which is given for preeclampsia is early onset, when the onset starts before 34 weeks of pregnancy. Also, sequence of events develop, and progressively this disease progressively worsens, and we often have to terminate the pregnancy just at the completion of 34 weeks if it is severe enough. And the late onset preeclampsia, where the patient may be hypertensive, but the preeclamptic symptoms, they start developing after 34 weeks of the pregnancy. And these are the patients, although they are late in development, but the babies, they are not acclimatized to the raised blood pressure, and the fetal complications are very commonly seen in this group of patients as compared to the early onset, where the fetus gets adjusted to the raised blood pressure and the reduced flow. So although it is late onset, but the fetal complications comparatively are seen more in the late onset definition. Similarly, a mild preeclampsia and severe preeclampsia, these two terminologies were earlier being used. Now it has been recommended that not to use the word mild, because this dilutes the complication possibilities associated with preeclampsia. Any preeclamptic patient, may be a mild or a severe variety, can anytime culminate into a severe form without any warning signs And this can be so unexpected that the patient may land up directly in the ICU setup or in complicated setup. So that's why we don't use the word mild. We either use the word preeclampsia or we call it a non-severe preeclampsia. And when the blood pressure is more than 160 by 110, or when the biochemical parameters have changed of the end organ damage to a more difficult, I must say that more severe forms, then we start calling it a severe preeclampsia. So preeclampsia and severe preeclampsia, or we should use non-severe preeclampsia or a severe preeclampsia. We should not use the word mild preeclampsia. So terminologies like pregnancy-induced hypertension or impending eclampsia or mild preeclampsia, these terminologies nowadays being outdated and we should not use them. So this chart I've already covered. Less than 20 weeks, if the blood pressure is raised, we usually consider it's chronic hypertension. More than 20 weeks, it's new onset. And we consider it's either gestational hypertension or preeclampsia and later on. If we talk about symptoms and signs of preeclampsia, I must say we call it as silent killer because often these women, they are asymptomatic. So we may come across a patient who is pre-eclamptic. Maybe some biochemical changes have changed, means she may be having proteinuria, but if it has not been tested, we will not be able to find her. BP, if it has not been monitored, she will not. She may come up with smaller things, vague complaints, which is often considered as normal in the pregnancy, like swelling of the feet, mild headache, often vomiting. So these things should never be considered lightly if they are having the woman is having it after 20 weeks of pregnancy. So swelling, headache, vomiting, breathlessness, blurring of vision, epigastric pain, or some urinary dark colored urine, and all these things, they should never be considered lightly, and women should be made aware of these things. If we have identified that this woman has a high risk tendency of developing hypertension, so we should counsel them, we should inform that these are the important symptoms which they should follow and come immediately, report immediately for that. Similarly, the signs, like we should measure the blood pressure, we should measure the proteins in the urine by dipstick or a spot test. We should check for edema. Weight gain का follow up बहुत important होता है. Reflexes often we can change. If she is complaining of some blurring of vision, we should check for the retinal edema and all those things. So this is important. This is pathophysiology. We all know that it is the placenta which is responsible for the preeclampsia. Here the spiral arteries are there. The uterine artery, spiral artery changes are there. Because of the trophoblastic invasion, they dilate and it supplies to the placenta. But placenta releases PLGF, the growth factors, and it causes the endothelium to survive and the pregnancy grows well. But what happens in the preeclampsia, this changes in the spiral arteries, they don't take place. The trophoblastic invasion is missing. Because of that, the placenta remains ischemic. The supply is less. Because of ischemic placenta, it releases some cytokines, some substances like SFLT, which counteracts the effect of VEGF, and that's why this endothelium gets damaged. Endothelial dysfunction becomes prominent, and this endothelial dysfunction causes the systemic changes or systemic complications associated with preeclampsia. That is, it can lead to renal problems, HELP syndrome, eclampsia. Excuse me, just a minute. Huh? So this is what is the thing which is there in the preeclampsia, and which is responsible for all the systemic complications of associated with preeclampsia because of these vascular endothelial damage which happens and takes place. And the common organs is all the vital organs gets affected, be it it's a brain, be it is the lung, the kidney, the liver, and of course somehow because of leaky vessels, the intravascular volume comes out in the extravascular space, and the blood volume becomes less, and it also leads, that's why it leads to the reduced flow in the fetus, also leads to FGR, oligohydramnios, and sometimes it raised blood pressure associated with abruption kind of a thing also. So placental ischemia, change in the PLGF, all these things are associated with the complication possibilities. HELP syndrome, we all know, hemolysis, liver enzymes, and low platelets. Hemolysis is when the peripheral smears have damaged RBCs or the LDH. Because of the damaged RBC, the LDH is released and the values turns to double the normal, that is around 600 levels. Proteinuria can be measured by different ways, but the usual manner of assessing proteinuria is the immediate test is by the doing a dipstick test. Although it's not considered very good, but it gives an immediate identification that if it is the value is more than 1 plus or a 2 plus, it means it's a significant proteinuria. Otherwise, the more definitive test is 24-hour urine collection, but you will collect it and then you will send it testing. You will get the diagnosis late. So the another spot diagnostic method is to check the urinary protein to creatinine ratio. So if it is more than 30 milligrams per millimole, then it is considered that it's a significant proteinuria, and it is considered as the diagnostic cutoff for the renal problem created by the hypertensive disorders of pregnancy. Now, coming to the management aspect of hypertensive disorders of pregnancy. So first thing is, whenever the blood pressure is raised, we need to know about the antihypertensives which are safe in pregnancy. So we have the preferred agent is labetalol and the nifedipine, and often for the emergency hypertension or and severe kind of a preeclampsia, often we can use in hydralazine also, but more frequently we all have experience of labetalol and nifedipine. And yes, of course, for the non-severe ones, we have the oral formulations of labetalol, nifedipine, and of course earlier we very frequently we used to use methyl dopa, which we have now reduced to a very less preferred, because it's a milder agent and it can has its own risk also. So severe hypertension, whenever the blood pressure is more than 160 by 110, we should start the therapy immediately. We don't have to wait for 4 hours interval to see. That is, repeat the BP in next 10 to 15 minutes. And again, the BP is raised after that's 10 minutes of rest, then it means that this patient needs to be admitted, to be given immediate some antihypertensive agent, and labetalol intravenous is the preferred thing. We have to control the blood pressure, but we should not control the blood pressure very fast. It is again very much important. Optimization is to 130 by 85 millimeter Hg. Sudden and severe fall of blood pressure should be avoided, because this can lead to complications not only to the mother as well as to the fetus also. Severely non-severe hypertension, where we use these 3 drugs. The labetalol for the oral preparations, we start usually with 100 milligrams twice daily, then thrice daily we increase to 200 milligrams, means 2 tablets. Similarly, the maximum dose which we can give for the labetalol is 1200 milligram. It is important that asthmatic patient should not be given a labetalol. And if you find across the patient is bradycardic, so again some evaluation has to be done prior to prescribing labetalol. So labetalol should be avoided in the patient if the heart rate is less than 60 or around 60. Nifedipine is a good drug. It can different formulations are there. The normal nifedipine, the sustained release nifedipine, and we have some fast acting capsular form also. So depending upon the severity which we want to use. So commonly we use this thing 10 milligrams. We start with BD or a TDS, and depending upon the severity, we can increase it to 20 milligram TDS or even 30 milligrams dose. And the maximum dose in 24 hours is 120 milligrams per day. Again, the methyl toba, the maximum dose is 2 grams per day. That is which we should use 1 tablet, one particular thing starting. Preferably the first line is called labetalol, and then if it is not going to control with the 200 TDS, we usually prefer to add the second one instead of going to a maximum dose of the one drug. Once we have at the 2/3, मतलब second dose rise कर दिया, उसके बाद भी if it is not controlled, then it is better to add the second drug instead of going to a maximum dose, so that synergistic effect can be achieved. Targets I have discussed that we should maintain the blood pressure of around diastolic of 85 millimeter mercury and the systolic blood pressure of 130 millimeter. We should not try to make it 120, 80 or 110, 70. This should be avoided. Simultaneously, the next aspect which we have to define through the patient is lifestyle and dietary modifications. Balanced diet, timely diet, more of the fresh fruits, more of the fluids, reduced salt intake to some extent, processed food should be limited, and the regular physical activity. These counseling has to be given at each and every visit to these patients who are identified as high risk or who has been identified as hypertensive. So 150 minutes of moderate intensity exercise per week or 30 minutes per day is a very important aspect which we will. The next important aspect is once we have diagnosed that she is a hypertensive patient or pre-eclamptic patient, we should follow. These patients should be followed up seriously. A mild hypertensive patient can be followed up on the OPD basis, while the severe hypertensive patients need to be admitted, identified, titrated, and once they are on tablets, they should be allowed to go home with the home monitoring and at a regular interval follow-up, weekly follow-up or a 2 weekly follow-up depending upon the severity and the gestational age. So blood pressure, symptomatology, what we have to check in every visit is we have to measure the blood pressure properly, correctly, the patient sitting in a proper position. Symptoms we should ask for, clinical examination we should check for dipstick urine every visit. CBC and platelet counts, again, very much important. Creatinine, liver function. So LFT, KFT, these things are very much important and has to be checked because these are the most common parameters which change first. And the frequency of these things has to be dependent upon the severity of the disease. If it's a severe kind of a preeclampsia, we have to be more vigorous in testing. That means we have to go it every third day or twice a week kind of a thing. Or if it's a mild kind of thing, we can ask the patient to come every week because a common non-severe preeclampsia can anytime convert into a severe preeclampsia. So that's why the follow-up plan is to check that whenever she goes to severe preeclampsia, we should admit her and then plan the delivery accordingly. So this is the importance of monitoring. After the maternal monitoring, it is important to go for fetal monitoring. Very high chances of fetals developing growth restriction. So fetal movement count, non-stress test whenever she comes up after 32 weeks of pregnancy, ultrasound for growth every 2 weekly, or if she's already known hypertensive case, amniotic fluid assessment either by AFI preferably, and the umbilical artery Doppler because to identify whether she's in stage 1 FGR or a stage 2 DFGR, because we have to terminate the pregnancy. We have to plan the termination of pregnancy both for the maternal. We may need to terminate pregnancy both for the maternal as well as neonatal sake point of view because termination plan depends upon both these things. So fetal interpretation may, if we are getting on a Doppler that is reverse end diastolic flow or the absent end diastolic flow, then it is a time to think over that this patient will require termination of pregnancy in some time. RDF means immediate termination. Ductus venosus may, if the pulsatility comes up, it means it is suggestive of fetal acidemia. It's a very poor prognosis. Immediate termination requires. If the blood pressure is raised to to great extent and it's not getting controlled or the fetus is developing these things before 32 weeks, we need to give her steroids for the lung maturity and we have to give her magnesium sulfate for neuroprotection point of view. So these are the things which we have to check. And while doing a Doppler, the commonest two vessels which we have to see for the assessment of the fetus is the umbilical artery and the middle cerebral artery, and the ratio of middle cerebral versus the PI ratio of middle cerebral artery with the umbilical artery. This is considered as cerebroplacental ratio and it should always be more than 1. If it is more than 1, we can continue the pregnancy format. So this is the targeting point, that how to decide when to terminate the pregnancy. So if it is REDF, reverse end diastolic flow, we should terminate the pregnancy. If the vectors venosus changed, it is a time to terminate pregnancy. If the CPR is coming below 1, then it is again also an indication that we now have to think about termination of pregnancy. We may not have much more time left with this one. Similarly, for maternal evaluation, we have to evaluate each and every organ system. We cannot think of just doing an LFT, KFT will work. We have to go for fundoscopy also, for the cardiac evaluation also. So in the case of severe preeclampsia, we always should better to admit the patient, control her blood pressure, explain her what all to see, and then accordingly, based on her gestational age, we have to decide the birthing plan. So when to terminate, when to end the pregnancy, how to end the pregnancy. Now these questions come up. So birthing indications for on the maternal side is if the patient is of preeclampsia or gestational hypertension and reach 37 weeks, it's a time to terminate the pregnancy. No more further expectant management. 37 weeks, better to induce the pregnancy, induce the labor. If the blood pressure is not controlled, she has been on 3 antihypertensive. This is again a sign that this is a severe thing. Now we should not further extend it. 3 drugs, again, severe preeclampsia with HELP or impending signs of eclampsia Abruption, of course, we all know that it's a time for retinopathy changes, papilloedema if it is there on fundoscopy, pulmonary edema if it has established. First, manage the patient. The woman has to be managed first and then terminate the pregnancy. So pulmonary edema, diuretics has to be given and then termination of pregnancy. This will save the mother. Otherwise, we may lose her. Hypertensive emergencies, yes, of course, of very severe hypertension, not responding to anything. So we have many trials.
Excuse me, ma'am, could we wind up the session?
Yes, I will try to cut short. So we have multiple trials. The time for termination is 37 weeks, or if it is an early onset severe hypertension not being controlled or any of these things which I have said for termination, then 34 weeks is the next second point that we should terminate the pregnancy if it is that much severe and these kind of things. How to deliver, then it is the next thing. The induction of labor can be done at 37 weeks if the obstetrical part is normal. But if there is any obstetrical problem like placenta previa or an malposition, or if it is a fetal problems in the form of Doppler changes like AEDF, REDF, or severe oligohydramnios, it is better to terminate the pregnancy with cesarean section because baby will not tolerate the labor in such a circumstances. So all these things we have measured. Intrapartumly, what we have to do is we have to be more vigilant for the blood pressure, hourly monitoring of the blood pressure, or if we have the monitors, then we should continuously monitor. Cut short the second stage of labor, we should try to cut short and give an active management. Methergine should be avoided because it raises the blood pressure further. So postpartum hemorrhage is again a very complicated, very common thing which often seen in association with hypertension of pregnancy. So we have to be vigilant. We have to be prepared with this thing. And after the delivery, most of the patients who have got because it's a placental related disease, once the placenta is out, most of the time 70 to 80% patient the blood pressure becomes normal and we don't need to give anything antihypertensives. So we have to just monitor the BP hourly for the first 24 hours to see whether she needs a antihypertensive therapy or not. If the blood pressure is still raised more than 140/90 persistently or 150/100 touching, then it is important to start some antihypertensive again in the postpartum period also. We can add furosemide also in the postpartum period safely, which we usually avoid in antenatal period because it reduces the blood flow. So last but not the least, the thing I should make out, the prevention of HDP is again very much important aspect which we should do, and we should counsel our patients. So the factors which help us in preventing aspect is first, if we can identify who is the high risk, and this high risk identification is done by Gestosis score, a very good score given by which has come up from the Foxy and our Indian people. The MAP, that is mean arterial pressure, the uterine artery Dopplers, and if we have the facility, then we can have these some tests like PLGF and SGF. So Gestosis score, we all know, we take a history. So there is no investigation which is required. It is just the history and the blood pressure monitoring, which gives us the scores, and based on that we can identify that this is a high risk patient, and all these high risk patient identified either by the Gestosis score, which can be done on the very first visit of the pregnancy. We can do this score, screen the woman, and once she's screened positive, we can go for a next level test, which is the second level screening, which is the uterine artery Dopplers. And if those is also positive, it is better to start the preventive therapy, that is ecosprin. Ecosprin 150 milligram, preferably given at the time of bedtime. This is the prophylactic treatment for this group of patient, and it reduces the it reduces the chances of developing the hypertensive disorder. So this is the last slide, that exercise timely identification of the high risk group in the first trimester itself by some screening, and starting the woman with the ecosprin, giving more amount of calcium, and the regular antenatal care, regular monitoring of the BP, and the timed birth is the crux where we can identify, manage these group of patients safely so that they can have a good maternal and fetal outcome. Thank you very much.
Thank you so much, Shikha madam, for this excellent presentation and covering this vast topic so nicely. I would like to invite Dr. Seema Malhotra madam to give her expert comments. Dr. Seema Malhotra ma'am, are you there?
Seema, it's not visible.
I don't think she's joined. At least
So,
she's not live.
Dr. Renu Tandon,
Dr.
madam.
Meera is there.
Yeah,
Dr.
Yeah. Just wanted to say that there is a guideline was released by Dr. Bhaskar Pal. 1 minute. ICOG and Justice. So it's there on the website, which is definitely we have consulted all RCOG, ICOG, and everything. So we have made a Foxy guideline. All can have a look. Okay. Otherwise, I'll share with Kanchan and Dr. Saroj Singh. She can share with them.
Dr. Renu Tandon, madam.
Yeah, Dr. Shikha, it was really a nice and enlightening talk. Many of the concepts that we had forgotten were made clear today. And it was a good revision. Thank you so much for the talk.
So,
Thank
for
you.
next,
Very expensive, Shikha. Well done.
Thank you. So time was a bit less, but then we have to cover so many things. But yes, of course, this is very much important that we should counsel the patients. It's again the important aspect. Thank you very much for giving the chance.
We now move forwards towards our third scientific session. Obesity is one of the major significant public health challenge at present, and it has emerged as it affects women across every stage of life. Right? It affects fertility, pregnancy outcomes, PCOS, even endometriosis, menstrual health, and menopause. Also, there is increased chances of diabetes mellitus, hypertension, cardiovascular disease, and several cancers as well. So the topic for the session is beyond the scale, obesity in women. Now, I respectfully invite our esteemed chairpersons for this session, Dr. Veena Gupta ma'am. Actually, I think she will not join today because she's busy in some other Foxy program. Dr. Deepti Chaturvedi. She is my president at present at Gorakhpur, and she is a consultant and co-director at Dr. Chaturvedi Cancer Hospital and Research Center. She is convener Foxy Gynae Oncology Committee at Gorakhpur, and she's ambassador for CCMB NIGF and also secretary Oncology Integrated Research Foundation. She has been vice president of GOGS. She is scientific secretary of Gorakhpur Obs and Gynae Society and has been cultural secretary of GOGS in the past. And our second chairperson is Dr. Amrita Chaurasia, ma'am. She is the professor in HOD at MLN Medical College, Allahabad, and she has 22 years of teaching experience. And she is at present secretary of Allahabad Obs and Gynae Society and has received Mission Shakti Award by UP government and a gold medal for best research paper in 2018. Now I invite our chairpersons to start the next session. Our next speaker is Dr. Kanchan Sharma, ma'am, and she is the chairpersons. Please introduce Kanchan Sharma, ma'am, for the next session. Deepti, ma'am.
Okay, I'll do it. Dr. Kanchan Sharma is MBBS MS FICOG, FICMCH, and she is National Chairperson of Non-Communicable Diseases Committee Foxy and the President Kanpur OBGYN Society, Director and Senior Consultant Akash IVF Kanpur, practicing for last 35 years, laparoscopist, colposcopist, and ART specialist. She has many academic achievements and she has organized many national conferences and has many publications to her credit. Awards and achievements are many, innumerable. Welcome, Dr. Kanchan Sharma. Please
Can I share my
share your
screen?
deliberation. Sure,
Yes,
sure.
ma'am.
Yeah. Thank you very much, Dr. Deepti. I first of all want to thank ICOG platform, Dr. Bhaskar Pal sir, Dr. Sheila Mani madam, Dr. Pratik Tambe, who is ICOG secretary, Dr. Narendra Malhotra sir, Dr. Kiran Pandey, Dr. Preeti Kumar, and all the dignitaries who have joined. Congratulations to conveners, Dr. Saroj and my hum name, Dr. Kanchan Prasad and Dr. Upma. Thanks to chairperson. The topic chosen are very good. Obesity consensus was there also in Pondicherry, and we reached to some definitive consensus we had, and the Foxy will share it. Before starting my talk on obesity, कमर की बढ़ती हर एक इंच कहानी, कमर की बढ़ती हर एक इंच कहानी कह जाती है, कई बीमारियों की दस्तक ये पहले से ही दे जाती है. So the rising obesity crisis there in India, as we all know. And this is a magnitude of the problem which we see in India. You see that trends of obesity is increasing in every state, especially in Delhi and Punjab, as is highlighted here in this graph. In September, now September month is coming, it's a Poshan Mah, and from September 2021, this has been started that both undernutrition and the overnutrition, that is obesity, that also come under this category. So India's obesity challenges are too many, and if obesity grows on this rate, in 2015, children and the adolescents will be 70 million, and to be either overweight or the obese. So we have to look into this data and try to control it. Obesity is defined as the excess or abnormal fat accumulation that presents risk to health. Obesity is a chronic disease that is increasing in prevalence in adults, adolescents, and the children, and is now considered to be a global epidemic. So prevalence of obesity is higher in females than the males across all the socioeconomic levels and the age group. So in India, we have seen that obesity is increasing continuously. So what are the learning objective in this very talk? We will classify the obesity and see the list of adverse effects on high BMI in the women of the reproductive age group. We will understand the pathogenesis of the adverse events related to obesity, optimizing pregnancy outcome in pregnant women with the obesity, and steps to prevent the obesity. So if we classify according to BMI, I will take only Asian data. Underweight is less than 18.5. Normal is 18.5 to 22.9. Overweight is 23 to 27.4, and obese is more than or equal to 27.5. Everybody know how to take BMI. Type of obesity, as we always explain to our juniors that, and to the patient also, that whether the apple shape and this is the pear shape, what is better? Pear shape is better rather than the apple, because in this there is more visceral fat, higher risk of the weight related health problems. So waist hip ratio is a very important parameter that is to be taken. Here waist diameter is at the narrowest part in inches, while hip diameter at the widest part in inches. In the woman, it should be less than 0.85, while in the men, it should be less than 0.9. So how obesity affects you? Because the visceral fat function as an active endocrine organ. So it is associated with dysregulation of the organ through the various pathways. These may be metabolic, may be vascular, may be inflammatory. The metabolic because of the insulin resistance, vascular because of dyslipidema, inflammatory because of the oxidative stress. So obesity and women's health, we see that each stage of the woman's journey from menarche to menopause is being affected by the obesity. This is prepared by Ministry of Health and the Family Welfare Government of India, how obesity affects you. Obesity affects every stage. There are many pregnancy problems, sleep apnea, increased risk of cancer, high blood pressure, heart diseases, kidney diseases, There may be diabetes, more incidence of diabetes in obese ladies, increased risk of stroke, fatty liver disease. So, as discussed, that obesity affects you by causing problem at different levels. It may cause metabolic problem, hormonal problem, mechanical, and the mental. Mentally, the obese patient, we see that they are more depressed, they are more anxious mechanically, because today is the osteoarthritis, today is the joint day. So, obese ladies, they suffer more of the osteoarthritis, their chronic back pain, SUI, and GERD. Hormonal, these obese ladies may suffer more of the infertility, AUB, and the cancers, especially endometrial and the breast. Metabolically, they are more prone to diabetes, CVD, dyslipidemia, gallstone cancers, and gouts. This is a graph which shows that how there is a relative increase of the risk with the obese ladies of the type 2 diabetes, hypertension, cholelithiasis, and the chronic heart disease. So there are impacts of the obesity on fertility in the male as well as the female. In the males, what does it cause? This adipose tissue that causes aromatization of the testosterone to estrogen, and thus there is a reduction in LH and FSH and the male gonad hypogonadism. This in turn causes decreased spermatogenesis, sperm DNA fragmentation, and male infertility. Same is caused by the ROS and pro-inflammatory cytokinins. While in the females, there is reduction in hypothalamic leptin resistance, and altered GnRH pulsatility due to hyperinsulinemia and reduced GnRH responsiveness to kisspeptin. Therefore, the GnRH causes altered GnRH pulse frequency, which favors the LH secretion and the androgen production, decrease LH amplitude. And this in turn affects the target organ. These are the endocrine and endometrium and the ovary. So there is everything which is altered. There is increased follicular atresia, hyperandrogenism, metabolic defects leading to increased rates of aneuploidy, oocyte mitochondrial damage, leptin-mediated supplementation of suppression of AMH expression, and altered follicular fluid composition. That all happens. This obesity, if the lady become pregnant, it affects in each and every step. Antenatally, it can cause many things which I'll sporadic and recurrent miscarriage, congenital malformation in the fetus can be there. There may be increased chances of hyperglycemia, hypertension, as well as the obstructive sleep apnea. While during intrapartum period, this may cause more chances of the induction of the labor. In obese ladies, there is difficulty in fetal monitoring. There may be shoulder dystocia, BPH, high rate of cesarean section are there in these, and increased need for HDU and ICU care. While after the delivery, if episiotomy is there or the cesarean section, the surgical site infection chances are more. There are more chances of thromboembolism. There are more chances of lactation failure, and even postnatal depression and risk of developing NCD later in their life. So, is the effect of obesity in the perinatal outcome? They have different effects on the fetal growth, macrosomia, stillbirth, preterm birth. They are responsible for asphyxia and even the failure of lactation, poor cognitive and performance, even neurodevelopmental disorders, including cerebral palsy may be there, and childhood obesity and type 2 diabetes may be there in these children in the future life. So you have to be very, very conscious. This is a fetal origin of the adult disease. In utero, immune response, inflammation, pro-inflammatory cytokinins, they cause the placental adoption. In turn, there is a fetal reprogramming, And in the childhood obesity, there is islet cell dysfunction, cardiometabolic disease, and as such, neuropsychiatric disorders. And in future life, there may be dysregulated lung development, asthma, atopic dermatitis, and even increased chances of cancer. So impact of obesity, long-term effect may be there on the maternal as well as the on childhood. So counseling of an obese woman is very important in the case of infertility. Even if they lose 5% of the weight, there is a meta-analysis on 18 studies. They say that if such patient lose the weight, it improves the chances of conception. So counseling of the obese woman to optimize weight before planning pregnancy is very, very important. So management of the obesity should be lifestyle modification. You should advise diet and exercise for energy balance. Whether you advise yourself or you keep nutritionist to guide the patient. Assessment and the management of the mental health status, medical management, and bariatric surgery in extreme cases. So management options for women with obesity may be physical activity, nutritional medical therapy, psychological intervention, or bariatric surgery in very, very obese patients. So calories, if we see calories intake, this diagram is very important. You keep it in your OPD and make understand to your patient whether if you take more calorie and less output, then you will gain the weight. In the same way as you fill a box, if you put more and take out less, then this will bulge or rupture at a day. Physical activity approach, it is supervised, built up gradually as per the fitness level of the person, up to 45 to 60 minutes of the moderate intensity physical activity a day. It has to be over and above the routine activity. Any activity, walking, swimming, dancing, many ladies, they are saying that we are very obese, we have joint pain, then you can advise swimming to them. Climbing stair is a very good exercise. Gardening is very good exercise. You can encourage them accordingly. Dietary approach is very important. Flexibly individualized approach based on personal preferences should be there. It must be balanced calorie and energy deficit. Inform protein-based diet, individual satiety, and reduced food cravings. Regular monitoring by apps. There are certain apps nowadays. They guide you for your calorie. They can take their help. So pharmacotherapy indicated if initial BMI is more than 35 plus at least one weight-related comorbidity may be used at a lower BMI cutoff for South Asians, Africans, and Middle Easterns, usually reduced by 2.5 kg per meter square, as they have higher prevalence of visceral obesity and cardio metabolic risk. So available options, medicine now, semaglutide and tirzepatide, liraglutide. Sema and tirzepatide, many persons are using. Regular review with the weight monitoring and reinforcement and adherence to behavioral changes should be there. So comorbidities or the condition that can improve after the bariatric surgery, these are the cardiovascular, hypertension, idiopathic, non-alcoholic fatty liver disease with or without steatohepatitis, obstructive sleep apnea, type 2 diabetes. These are in very obese persons. So in short, mechanism of action of GLP-1 receptor agonist, semaglutide and liraglutides. These are oral tablet as well as the injection. Micronutrient supplement must be prescribed. Lags for contraception, as spontaneous conception can occur in infertile women. Drug should be stopped 2 months before planning conception. Tirzepatide is a synthetic polypeptide and dual agonist for the glucagon-like peptide and glucose-dependent insulinotropic polypeptide receptors. This is seen in this diagrammatic view, very good way to show its action. Pharmacotherapy for obesity, WHO guideline is emphasize long-term use of GLP-1 based therapies with intensive behavioral therapy to maximize and sustain weight loss benefit. Emphasize the urgent need for framework to expand equitable access to these medications. Surgical approach, where we offer this, where the BMI is more than 40 or 35 kg minus 39.9 kg per meter square to 39.9 kg. So in this high BMI, these are the surgical approach. You may, the surgeon may apply the gastric band, may by the gastric ballooning, by the gastric bypass, by the sleeve gastrectomy. So prevention of the obesity should be by raising awareness of the importance of the healthy lifestyle, raising awareness of management options available for the management of high BMI. There should be opportunistic screening, measure the BMI and the waist circumference of all the beneficiaries, counseling of a healthy lifestyle and the health benefits with that. Focus on the women seeking treatment for young girls with PCOS, infertility, postpartum mother with high BMI, menopausal women with the menopausal symptoms. To conclude, overweight and the obesity are the chronic, relapsing and progressive condition characterized by excess body fat. They are associated with an increased risk of morbidity and mortality due to diseases like diabetes mellitus type 2, dyslipidemia, hypertension, CVD, cancers, etc. It affects women across their lifespan. It is significantly associated with infertility, miscarriage, stillbirth, high-risk pregnancies, and long-term neurocognitive and metabolic advices, which affects on the fetus born to obese mothers. So we must screen everyone coming on contact with us for medical advice or otherwise and make them aware of this disease and its treatment. So now the obesity comes under a disease. So take the first step in faith. You don't have to see whole staircase, just take the first step. That is told by Martin Luther King Jr. So thank you very much for patient hearing and giving me this platform to talk. Thank you very much.
Thank you, Dr.
Thank you
Kanchan.
very much.
Yeah, it was, I really extend my sincere gratitude to you for delivering such a insightful and engaging talk and your evidence-based approach and practical recommendations, an emphasis on how to prevent and the holistic management, which has really provided us with dealing with obesity at various stages of life in a woman and the consequences if we don't control the obesity. And we have to not do body shaving, but tell them the forthcoming problems that they can end up with, and ask them from the lifestyle modification to semaglutide and many other drugs are available to reduce weight and all that. It was really a very lovely lecture. But I was just asking something little bit about myoinositol and metformin. Could you please show some light on that? Dr. Kanchan, please.
Actually, I had
Dipti
also
ma'am,
PPTs
you can
here in
mention.
about the myoinstall, and as Kanchan Prasad want to say that we have less time, so I omitted those slides.
Okay, okay.
Dipti ma'am,
But
you can
in
ask
short,
query in the chat box. Meanwhile, we can continue with
okay.
that
Oh,
activity.
sure. Okay.
Thank you.
Please proceed.
So thank you to all
Thank
the
you
three
so much.
speakers. Fantastic
Dr.
talks,
Prateek, sir.
evidence-based,
Yes.
well delivered. Thank you very much for being here with us. I'm sure the audience who is on the audience link, which we can't see here because we are on the faculty link, will also have appreciated all the three talks. Thank you very much to all of you.
Thank you. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, ma'am. Now we move on to a very interesting panel discussion on PPH, Prevent, Prepare and Protect, a case-based discussion. And we have a moderator, our very dynamic Dr. Kanchan Prasad, madam, from Moradabad. And as we all know, she was a North Zone Coordinator, Foxy IAC Committee.
Thank you, ma'am. Please move ahead. Thank you so
And
much.
we have our experts, जो कि गुरुजन हैं हमारे. We have Dr. Kiran Pandey, ma'am, and Dr. Saroj Singh, madam, from Agra. Then we have our panelists, our esteemed panelists. We have Dr. Anita Nath from Bareilly. She is Secretary of Bareilly Obs and Gynae Society. A dear friend, Dr. Meera Laktakkia, madam. She is Senior Consultant from Prayagraj, and she is a Manyata champion. And she's worked in many projects. Then we have Dr. Preeti, who is Secretary from my society, Mathura Obs and Gynae Society. We have Dr. Sonam Rastogi ji from, she is Moradabad. She is Secretary from Moradabad Society. And then we have Dr. Ramneet Ahuja. She is Medical Director of AMRC Kanpur. And she is a great gynae laparoscopic surgeon and fertility specialist. Then from Gorakhpur, again, a very dear friend, Dr. Babita Shukla, madam. She is ex-secretary of Gorakhpur Society. And last but not the least, we have Dr. Mona Asnani ji, and she's additional professor from KGMU, Lucknow, a very dear friend. So now handing over to Dr. Kanchan Prasad ji for a very interesting panel discussion.
Thank you so much, Dr. Vartika, madam. And let me share my screen. Okay, is my screen visible?
Yes.
Yes.
Okay. Yes. Okay, so welcome to the panel discussion on PPH, a very common topic, but still a very important cause of maternal morbidity and mortality. So perhaps we need to keep revising it very frequently. And so I welcome my panel expert, Saroj Singh madam and Kiran Pandey ma'am. Perhaps Kiran Pandey ma'am is a bit not well, so she has not joined. And my esteemed panelist, Anita Nath ma'am, Meera Laktakia ma'am, Preeti Amarnani madam, Sonam Rastogi, Ramit Ahuja madam, Babita Shukla ma'am, and Mona Asnani. So now we move on to panel discussion on postpartum hemorrhage, which will quick revision and some case-based discussion. Okay, for the introduction, we all know PPS complicates around 1 to 10% of all births and 25% of all maternal deaths are hemorrhage related, particularly in low resource setting. So let us come to the case number 1. A 25-year-old primary gravida has 16 weeks of gestation coming to you for antenatal care. All reports, blood pressure and obstetric USG are normal. So I'm asking, can she still have PPH during delivery?
Yeah, it is very much possible she might have PPH. Basically every pregnant woman is potential candidate for PPH. So we should not take any person lightly, any patient lightly. And definitely there are chances she might land into PPH.
Yeah, very nice. And how to prevent PPH in low risk women?
For that, we have to do active management of third stage of labor, as we have read.
No, right now she's not in labor. Right now she's not in labor. She's a low risk patient. She's just come in ANC.
We can correct her anemia.
Low risk,
We can correct our
rule
anemia.
out all the high risk factors, correct her anemia, because rightly said by previous speakers that anemia causes, it's one of the most important factor for landing us in PPH. Not only it affects the coagulation profile of the patient, but it also basically hypoxia of the myometrium. So uterus is not going to contract. So anemic patient is likely to have atonic PPH. So low risk patient है, आप सारे high risk factor को rule out कर दीजिए, and basically correct her nutrition, make her aware of all whatever she has to have, all the dietary components, and also give her all the high risk pointers, the danger pointers where she's going to how often she has to come for checkup and what all investigations we need to do, so that we keep her above 11 grams through all the trimesters as far as possible. This is what is going to be, I feel it's going to be the management for the low risk patient.
Very,
Along
very
with that,
right. Yeah. Yes, ma'am.
Dr. Kanchan, I just want to add one thing that
Yeah.
usually we do hemoglobin or CBC in the first visit, but it has to be repeated at least thrice. It's after 26 weeks and then again at 30 weeks, because
Every
it may be
trimester.
all
Yes, ma'am.
later on.
According to WHO, now in every trimester has to be done, because dilution of mid-trimester dilution is not taken into consideration. So
Yes.
आपको हर trimester में करना चाहिए, high risk में तो और जल्दी करेंगे.
Okay, so according to this study, the baseline incidence of PPH is in low risk vaginal delivery ranges between 6 to 19%. Why the risk of severe PPH is 4% of all. So yes, she is at risk of developing PPH. So how we are going to prevent it? Prevention in antenatal period, we need to encourage regular antenatal visit, because studies have shown that women having less antenatal visit are developing more incidence of PPH than the regular antenatal visit. Also, we need to check her hemoglobin at least every trimester, iron and folic acid supplementation, and intravenous iron therapy if needed to correct anemia. And also identify the risk factor of PPH and correct it timely, like anemia, PIH, gestational thrombocytopenia, which is very prevalent somehow in our area, and other coagulopathy. And risk, yes, the prediction of risk. This is Association of Women's Health Obstetrics and Neonatal Nurses. They predict risk scoring for predictive risk scoring for high risk and identification for PPH. This is a very good chart where the low risk has few criteria like no uterine incision, no previous uterine incision, less than 4 previous vaginal births, no known bleeding disorder, no history of PPH, and singleton pregnancy. There is a list of medium risk and list of some high risks like active bleeding more than bloody source, suspected accreta or percreta, placenta previa, low-lying placenta, any known coagulopathy, history of more than 1 previous PPH, hematocrit less than 30, and platelet less than 1 lakh. And if 2 or more medium risk items are found, they are classified as high risk. So we can screen the woman during antenatal period, and we can do timely intervention or refer them to higher center. So preventive mode, primordial, we have all studied in PSM, primordial prevention, primary prevention, secondary prevention. Primordial prevention start during the growing period only to prevent the development of underlying risk factor, that is improving female nutrition, adolescent anemia, discouraging grand multiparity, promoting general reproductive health, and we have discussed primordial prevention during antenatal period. Primary prevention is prevention of PPH occurring during childbirth, during immediately after childbirth, and we all know that is done with active management of third stage of labor. So what is, we all have read, just for a quick reason, what is active management, AMTSL? Anita ma'am?
Yes, active management of third stage of labor is actually to prevent the PPH. So in that first we give prophylactic 10 units of oxytocin, either intramuscular or IV, after 1 month, after 1 minute of delivery of the baby. And second is controlled cord traction. And third, the main thing is we should check upon the uterine tone. We should keep one hand on the uterus, suprapubic, and see whether it is relaxed or contracted. So that is of utmost importance. Even after delivery of placenta, we always check the tone of the uterus. So that is, and the main thing is our labor room and our staff should be labor room should be equipped and staff should be skilled. That is also of utmost importance.
Yes, very right, ma'am. So MTSL is consist of uterotonic drugs, just after birth of baby, and checking that no baby is inside, there is no second baby.
Yes, that is also important. It should not be twin or
Inside
triplet.
the uterus, delayed cord clamping, control cord laxness. control cord traction if the skilled birth attendant there, and assessment of uterine tone, periodic assessment of uterine tone to diagnose any earliest uterine atony. So uterotonic drug for AMTSL, we all know that any of the uterotonic drug after excluding another baby. So we can give oxytocin, we can give heat stable carbetocin, or if they are not available, or if skilled attendant is not there, then we can give misoprostol also. We all know the dose, 10 unit IM or IV. Oxytocin if cold chain is not maintained properly, and if the patient is affordable, if it is available, then carbetocin is a good option, where we give 100 microgram IM or IV. And even by health professional, if skilled health professional are present, even misoprostol will do 400 microgram or 600 microgram. And what is not recommended for AMTSL? Carboprost is not recommended because it has more side effect, and better drugs are available. And now sustained uterine massage is not recommended because it causes more discomfort to patient without any added advantage. And tranexamic acid currently is not recommended for active management of third stage of labor or prevention of PPH. Now, to the second case, primary gravida delivered vaginally a healthy term baby. Patient's vital were within normal limit after delivery. After 1 hour, the resident says there is not much bleeding per vagina, but patient pulse is 102 beats per minute. Systolic blood pressure is 96 and diastolic is 66 millimeter Hg. So, do you think it's a case of PPH? Any of the panelists?
Yes, she's a case of
Yes.
PPH. She's a case of PPH.
Okay.
Maybe
There is not much
could be.
bleeding by. Yes,
But her pulse rate is rising and blood pressure is 96 and diastolic is 66. So she's setting in for the hemodynamic imbalance. So the hemodynamic imbalance is the first sign, whenever if you even don't have bleeding, because she might be bleeding inside. It is not visible outside. So that
Yes.
Maybe patient may be anemic also. We can think that way also. Previously anemic patient.
Maybe she's developing hematoma
inside, yes, because right now she's not bleeding, but her pulse is gradually rising and BP is falling.
Yeah, very right. All the panelists are right. So let us come to what is the definition of PPH.
So any amount of bleeding which can make the patient hemodynamically unstable is the most appropriate definition. Though we have other definitions like loss of 500 ml in normal delivery, 1 liter after C-section, or the patient is changing pads quickly, like 2 or 3 pads in 5 minutes. So these are there, but the most, or there is a fall in hematocrit by 30%. But the most appropriate would be that bleeding which makes the patient hemodynamically unstable.
Yes, ma'am. So objectively measured blood loss threshold, classically we defined is 500 ml or more. But even if it is 300 ml or more, and unstable hemodynamics, that is pulse is more than 100, systolic blood pressure is less than 100, and obstetric shock index is more than 1. The normal is 0.7 to 0.9. We define it as a case of PPH. So, of course, he is a case of PPH because first, the resident told that bleeding is not much. It's a subjective observation. So she may be wrong, okay, because subjective observation estimation of blood loss is in 30 to 50% cases, it is wrong estimation. And second point, rightly, there may be concealed bleeding. Bleeding is not outside, but formation of hematoma. So she is a case of PPH. So postpartum hemorrhage classification and staging according to estimated blood loss or cumulative blood loss vary across the global obstetric bodies. So here we can see this table represents how different international bodies define PPH differently. WHO has classical definition of more than 500 ml in vaginal and more than 1000 ml in cesarean, but it has low threshold. He said low threshold of 300 ml plus abnormal vitals, where we should start taking actions by emotive response. FIGO has the same definition. RCOG has divided into minor, major, and moderate and severe, according to the amount of blood loss. Then ACOG has staged it stage 1 up to 999, stage 2 up to 1500, and stage 3 more than 1500 to more than 1500. And Foxy define is the classical definition and is defined massive or severe at more than 1000 ml of blood loss. And so according to this literature, visual estimation is inaccurate. Obstetric caregiver tend to underestimate blood loss by approximately 30 to 50%. Bleeding may be concealed and abnormal vital is more reliable. That is obstetric shock index. Okay. So once PPS is defined, it should be staged or graded by direct quantitative blood loss estimation or indirect by obstetric shock index. And we have discussed the staging and grading by direct quantitative blood loss estimation, and this is severity of PPH according to obstetric shock index. So we have discussed so what is the severe, how we define any of the panelists, how we grade it according to obstetric shock index.
The shock
So
index
normal is 0.7 to 0.9.
0.7. Heart rate upon systolic blood pressure. So 0.7 is normal.
Yes,
so the
yes.
more, see the heart rate upon systolic, the systolic is going down. The lesser it will be, the higher shock index of PPH, right? So more than 1, you know it is going to be, she's directly in the shock. As you said, 1.3. The more it goes above 1.3, she is in different in a critical condition, and 1.6 is obviously we need to, just, it's a red flag. It's a red flag. We are losing the patient. So above 1, activate everything, whatever we need to do.
Yes,
So
ma'am. And
basically,
0.9 to 1, we need to be vigilant.
Yes. The moment you see the PPH is occurring, your clock has started ticking. So you have to be vigilant from that point only. But yes, the battery of resuscitation measures you can take is according to the shock index, or you can explain to the attendant according to the severity of the shock index.
Yes, ma'am. And this is severity of grading of PPH according to grade 1, 2, 3, and 4. And RCOG has classified according to the estimated blood loss.
Blood loss.
We all know that. We all have discussed that. Now I want to ask Ramit ma'am, what is principles of management of PPH?
First of all, whenever we see such a patient, we have to call for help and activate the PPH protocol. That is, first of all, if we we have to resuscitate the patient, and same time we have to give the drugs that will control the bleeding. That is, the resuscitation is to be done by ABC, that is airway, breathing, and circulation. Airway, the airway should be patent, and the patient should be given 10 to 15 liters of oxygen by mass per hour. And circulation, in order to maintain the circulation, we have to at least place 2 wide bore cannulas. It can be 18 gauge or 16 gauge, and start with any of the crystalloids like ringer lactate. Maximum crystalloids which we can give should be not more than 3 liters, because if we give more, she might land up into dilutional coagulopathy. And same time, we have to send the investigation when we put the cannula. Send the patient for investigation. We should know the blood group, the CBC, all the coagulation parameters, APTT, PT, fibrinogen, then LFT, KFT, all needs to be done. And we have to, it's all a teamwork. We should activate the blood bank. We should call our anesthetist and our head nurse and any other obstetrician, senior obstetrician if available, or any colleague she might be called for in order to save the life of the patient. And the critical care unit also should be activated. Meantime, we have to give the oxytocin. That is, at least we can give we have to look for the tone and give, if she is a tonic, in that case we give oxytocin 40 units in 20 to 40 units in 1 liter crystalloid. And the rate of infusion should be around 500 ml in 10 minutes, followed by 250 ml in 30 minutes. And if oxytocin is not available, in that case we might give her methergin 0.2 milligrams, which can be repeated every 2 hours. And we can give this carbetocin if the availability is there, that is 100 micrograms IV or IM. If you are giving IV, then it is over 1 minute. And along with that, in low resource settings, we can give misoprostol. It can be given 800 to 100 micrograms per rectally, or 600 to 800 micrograms sublingually as well. and same time within 30 minutes of the onset, we can give her tranexamic acid. That is, we have over 10 IV over 10 minutes, 1 gram, and we can repeat it after half an hour. And along with that, we have to look, first of all, we have to look for then we have to assess the patient. What is the reason for the PPH? It is torn, then all these drugs needs to be given, and we have to rule out the tissue, whether any retained bit of placenta is there inside, trauma, that is if there is any vaginal tear, cervical tear, or any other, like any other tear is there, we have to rule out that. Or when we look for the investigation, we have to rule out the thrombin, that is factor, that is we have to look for all the coagulation parameters.
Yes, ma'am. Yes. So we are coming to that. So principle of management is we have to use golden hour. So we can remember it with order: oxygen supplementation, restore circulating volume, uterotonics drugs, evaluate response to therapy, and remedy underlying cause. And that avoids lethal triad.
And catheterize at the same time.
Hi,
Yeah, rightly added everything.
Yeah.
Catheterization.
Yeah. So oxygen, we all have discussed 10 to 15 liter per minute via face mask, irrespective of maternal oxygenation. Two large IV cannula, 16 to 18 gauge, because the flow rate is more than double from the 20 to 22 gauge. Fluid resuscitation start 2 liter crystalloid, and then if blood is available after 2 liters, give PRBC, FFP, and platelet in a ratio of 1:1:1. And if component is not available, then 2 unit PRBC can be given. And if delay in blood, then 1.5 liter of colloid may be given in order to resuscitate the woman. And RL is preferred over NS, as there is risk of hypochloremic acidosis with NS, and prevent hypothermia by covering mother and giving administered warm fluid. So, Meera ma'am, what is lethal triad? Or any of the panelists, what is lethal triad?
Lethal triad is hypothermia,
Hypothermia, acidosis, and coagulation failure.
Coagulopathy.
Yes, that is the most dangerous
PIC.
triad where patient can fall. So in spite of controlling the blood loss, if patient has fallen into this lethal triad, it is very difficult to now, the recovery road is very difficult. So now the lethal triad initially, now it is deadly diamond, where the three factor were there already: coagulopathy, hypothermia, and acidosis. Now they have added hypocalcemia. So if patient falls into trap of these 4 factors, the recovery is difficult. So we how to avoid it: balanced transfusion of fluid and blood products, early administration of tranexamic acid, keep mother warm, administer warm fluid, calcium supplementation after giving blood product, calcium gluconate, because the citrate in blood that chelates calcium. So hypocalcemia further cause coagulation disorder, I mean the problem in clot formation, and minimizing crystalloid, and also this area of research is permissive hypotension. This is not in clinical use.
All these 3 triad, provoke each other. Hypothermia, acidosis, and coagulative, they all, एक दूसरे को promote करते चले जाते हैं. So that's how patient falls into that, more dangerous situation.
So we need to manage the patient aggressively. We need to manage aggressively within 1 hour. Yes, ma'am. Yes, ma'am. And this I was talking about is permissive hypotension, where the physician keeps the blood pressure intentionally between 80 to 90 millimeter Hg, so that clot is not dissolved. But this is not in clinical practice. This is just research area to prevent the patient from bleeding further again. Babita ma'am, what is PPH care bundle?
So PPH care bundle is, there are set of actions which when done together, one after the other in a systematic manner, we manage things more efficiently without missing a step. And we also have a teamwork who is trained for such PPH care bundle. Each one knows what they have to do. So during the time of emergency, there is no chaos. For PPH, for example, we call for help and we follow the ABCD approach. And then we have that we put the IV line, we give uterotonics, you go for uterine massage, and you give tranexamic acid. Then you rule out the 4 T's, arrange blood, and if these things fail, then we go for compression maneuvers or UBT. So, like things are put together in a bundle so that all the steps are done. We do it otherwise also. But then if it is not, if it is there in a bundle care approach, we tend to remember and do it more systematically.
Yes, very correct, Babita ma'am. So it is actually 2 care bundle for facility implementation where we so the first response to PPH bundle, and if that the bleeding is not controlled, then response to refractory PPH bundle. So yeah, so the what is the first response to PPH? It is known by the mnemonics E motif, where E means E stands for early detection of PPH, where quantitative assessment of blood loss and check the postpartum abdominal uterus tonus to assessment for early identification of uterine atony is recommended for all women. And if we suspect that woman is having even slightest of PPH, we responded with the motif uterine massage and O for oxytocin drugs, T for tranexamic acid, and IV isotonic crystalloid fluids. So rapid institution of uterine massage, rubbing of uterus achieved through the manual massaging is recommended for the treatment of postpartum hemorrhage. We all know that. And administration of IV fluid, isotonic crystalloid or blood products, and the dynamic assessment of fluid responsiveness to guide further infusion and early utilization of administration of blood and blood products because excess fluid, we all know, can cause dilation of coagulopathy. So oxytocin, as madam has already discussed, what oxytocin we need to give in PPS, there is some first line drug and there is some second line drug. So first line drug is oxytocin and tranexamic acid, and second line drug is when oxytocin fails, ergometrin, carboprost or misoprostol. So this is the route, dose and route of administration. Oxytocin is administered, we all know, by infusion. Maximum dose is not more than 3 liters of IV fluids, and ergometrin we can give 0.2 milligram IM, and we can repeat up to 5 doses every 2 to 4 hours, a maximum 5 doses in 24 hours. We have to be very aware about, we do not give in preeclampsia, hypertension and heart disease, we all know that. And prostaglandin, that is we give intramuscular 250 microgram every 15 minutes, maximum 8 doses, and we do not give in asthma, and we have to take care of diarrhea and vomiting. And few points here I want to just highlight that oxytocin cannot be used if carbetocin was given in active management of third stage of labor, because carbetocin has equivalent affinity to oxytocin receptors and has longer half-life. Misoprostol should be given sublingual, not perrectal, as bioavailability may be less when given through perrectal route. And misoprostol, if misoprostol was used for AMTSL, no evidence of role of additional misoprostol. Tranexamic acid, what is the role of tranexamic acid, Dr. Sonam?
Yeah, it is an antifibrinolytic agent.
Yeah, so when should we give in a PPH?
Yeah, in PPH tranexamic acid, we should give 1 gram. If by oxytocin it is not controlled, then we can give 1 gram IV, slow IV, tranexamic acid, and even we can repeat the dose if after 30 minutes the PPH is still continuing. Or if there is a second episode within 24 hours, then we can repeat the dose of tranexamic acid.
Yeah, so it should be given as early as possible and especially within 3 hours of birth. Tranexamic acid, it has a role in management of PPH. Now E, the last E, there stands for examination and escalation.
Yes.
So how we assess, I think Preeti Amarnani ma'am, has she joined?
Yes, ma'am.
Preeti ma'am, has she joined?
Yes, ma'am.
So how we then how we reassess the patient and escalate our management or intervention?
We have to see the vitals, ma'am.
Yeah.
And we have to assess the how much the blood loss is there in.
Yes, so we then ensure bladder is empty. We have to check whether placenta is completely evacuated or not. Placenta is complete, whether any retained bed cells remain inside, and we should evacuate any clots. We should check for any tears with internal examination and escalate the response if does not stop after first response. So when to move to refractory PPH bundle 2? Mona Snani madam, has she joined?
Yes, ma'am, I'm there.
So if the patient is not responding to the early bundle, then we will move to the refractory PPH bundle. So what happens if the uterus has contracted and the bleeding is still happening? We have to suspect traumatic PPH and other two Ts which were not evaluated right now. But if the uterus is not contracting, then we have to go on to tamponade. It can be external. You have to give either balloon tamponade, uterine balloon tamponade in form of either Chhattisgarh balloon tamponade or ESM UBT, or it can be by external compression, either aortic compression or bimanual uterine
Yes.
compression should be given to
Yeah.
increase the tone of the uterus.
Yes, very correct. So the patient should be reassessed within first 30 minutes of diagnosis of PPH, and if first line intervention fails, to stop the bleeding, or if the vitals are worsening, then it is time to move to response to refractory PPH bundle. So so what is a response to refractory PPH bundle? Dr. Mona has already explained somewhat. Any other
we can go for stepwise devascularization.
Or any Ramit, ma'am? Yeah. Yes.
Yeah. Besides the compression suture, beside the bimanual compression and the balloon tamponade, we can go for compression sutures, that is V-Lynch sutures we can place, and we can go for this stepwise devascularization. We can ligate the uterine artery, ovarian artery anastomosis, then anterior division of internal iliac artery. We can ligate in order to save the uterus. If nothing works, in that case, that is the only end point when we plan the patient. Or we can, if we have a facility for uterine artery embolization, if we have a good
So this is
radiologist, then we can go for uterine artery embolization. And if nothing works, in order to save the life of the patient, we might land up with hysterectomy.
Peripartum hysterectomy. Yes. So response to refractory PPH bundle, it works in stepwise manner. We have to give compressive measures. The compressive measures are either we all know here. Either these are either aortic compression or bimanual uterine compression, and non-pneumatic anti-shock garment. So what these compressive measures do, they stop the bleeding temporarily. They are temporizing mechanical measures. So temporarily the drugs are not working, and we are waiting for surgical intervention for the patient, or we are waiting to transfer to higher center. So the second bundle which acts through is these temporary compressive measure. So awaiting for definitive intervention, for volume replacement, for transfer to higher facility. We can give aortic compression, we can give bimanual compression, or non-pneumatic anti-shock garment. So how do we give this aortic compression?
For that,
slightly above the umbilicus on the left side, we compress with our fist till the femoral pulses are not palpable. Then we are sure that we have actually compressed the aorta, and now we can reduce the bleeding by giving the aortic compression. That is the aortic compression method. In bimanual compression, we make a fist go from the anterior fornix, and abdominal hand will be on the posterior surface of uterus. In between our two hands, we have to compress the uterus so that the bleeding stops. That is bimanual compression. As you rightly told, non-pneumatic anti-shock garment is basically to buy the time till the patient can be shifted to a higher facility, or till the time the blood and blood products are available if the patient is going into shock.
Thank you. So now, very correct, Dr. Mona Asnani. And now we come to the uterine balloon tamponade. So, when to go for uterine balloon tamponade, we have already discussed when medical measures has failed. So this is recommendation by Foxy, is when to go for uterine balloon tamponade, recommended in case of refractory PPS due to atonic uterus, and it should be employed early before advanced shock develops. Procedure should be performed by competent healthcare provider trained and skilled in management of PPH. Other cause of PPH should be reasonably excluded, like any tissue inside, any placenta inside, any coagulopathy, or any traumatic cause should be excluded. And maternal condition can be regularly and adequately monitored for prompt recognition of deterioration, if any. So here the FIGO also recommend that uterine balloon tamponade devices are placed before onset of advanced shock. Then only it works properly. So, and what is tamponade test?
Garment, the moment you put the NASG garment, You can just deflate the third part, the third component, and you can put it in. So everything is going together.
Yes, ma'am. Yes. And what is tamponade test? When we put this balloon tamponade, what is this tamponade test?
The bleeding will stop and the pulse rate would decrease and the blood pressure would start rising, and patient would show the clinical signs of improvement would show. So that means the
Yeah, so
tamponade is effective.
Yes, ma'am. So following inflation of the balloon, the the bleeding will stop. That means laparotomy, it has worked and laparotomy is not required. But negative means it has bleeding has not stopped and patient need next set of intervention. Types of beauty or the panelist has already discussed. It has commercially available also and point of care made also, Chhattisgarh and other modifications. So this is and according to FIGO, the success rate of condom uterine balloon catheter is appears to be comparable to those commercially available. So we all as a practitioner should know how to prepare condom catheter or gloved balloon catheter for the management of PPH. Now escalation to surgical intervention. When to escalate, these temporary measures and these mechanical methods have not worked. When to escalate to surgical intervention?
When these conservative methods fail, or anytime you feel that patient is deteriorating, then you can move to surgical methods before that also. And you should be in a good tertiary center where you can perform all these measures.
Yes, Saroj ma'am wants to say something, madam.
I want to say that we can even use suction cannula, and those Samartham suction cannula and those Panicker cannula are available, and they also work very well. It can be used at places. And another important thing is we have discussed, or very nice discussion is going on. But another important thing is all these things should be ready with us. If you at the time of PPH, if you want to make balloon at that time, it will be very difficult. So majority of the time we used to make balloon catheter and everything bind up, and then it is ready. So whenever you need, you use it, and once it is used, replace it with the other. So because at that time is not there to prepare the balloon catheter at that time, and so it should be ready with us.
It should be an emergency cart of the labor.
Can I add, Dr. Kanchan?
Yes, yes, ma'am. Yes, ma'am. Please,
yeah, as Dr. Saroj said, SR cannula. Now in South, almost even every government hospitals we have it. Okay, so what happens, that preparing the balloon and putting that, and if they don't have the Bakri balloon because it is expensive. Okay, some centers are using Elavi balloon, but SR cannula really comes even during section also we can put, and it really helps. So we have a good experience with SR cannula, and I think as Dr. Saroj said, I think their institution they have it, and
Yes,
I think they have also done the
have done a
studies.
thesis of that also.
So
Even the
Dr.
balloon,
Saroj, try to bring it at government level, it will really help. Because blood banks are not available and so many problems are there. So if all of you can work together, with the recommendation now.
Yes,
And yeah, I think you can really do that. Yeah.
Thank you, ma'am. Thank you, Saroj ma'am. Thank you, Sheila ma'am, for the great input. So the failure of conservative or mechanical measures and women worsening vitals, traumatic cause of PPH or negative tamponadic testing, we have to escalate to surgical intervention. So this is the steps of sequential surgical management, which Ramit ma'am has already told. The bilateral uterine artery ligation, bilateral ovario-uterine anastomosis ligation, uterine compression suture, and bilateral internal iliac artery ligation. And if nothing works, then of course we have to do peripartum hysterectomy. One esteemed panelist has discussed about uterine artery embolization. What are the indication of uterine artery embolization? We cannot do in all cases. So what are the indications? I want to ask any of the esteemed panelists.
We usually go for uterine artery embolization in the patients who are actually hemodynamically stable, who are not willing for the further fertility. And just like in AV malformations and all, we go for uterine artery embolization basically.
Yes, it is used in refractory bleeding where, yeah, it is in where the refractory PPH, but the hemodynamically stable and appear to have persistent slow bleeding, and only them, and also you have to have interventional radiology facility available, and it is not recommended for brisk ongoing bleeding because that will not allow that procedure to occur.
So in
Role of uterine packing?
Just a minute, Kinshuk. In few cases,
Yes, ma'am.
even
Yes,
before start, like cases of placenta accreta or percreta, and where interventional radiology is available, then it can be used even from the beginning that you have catheterized uterine vessels, and if needed, inflate them, and that can be used where at those centers where it is available.
Yes, ma'am.
Prophylactically.
Yes, ma'am. Place the catheter before doing cesarean section. Take out the baby, and then after taking out baby, you block the you do the embolization. Yes, ma'am. Yes, ma'am. So I was discussing what is the role of uterine packing? Any of the panelists?
Previously, it was advocated.
Not much recommended.
Yeah, it's not recommended. It's not recommended by any of the international or national guidelines. It's not recommended. Yeah.
But it works.
Yes,
But
I
this
agree
works.
to it. It works.
It
It really
works.
works.
Whatever it is written in the book.
Tamponade
actually-
also, na? Instead of
Ma'am, Saroj ma'am, what is your comment?
No, not at all. Because uterine packing, when you are doing, your gauze is going up to what level? Because once baby has delivered, the uterus is nearly 22 week size. If you really want to pack, it should go right up to the fundus. Then only it will be of use. And when you are doing packing, it never goes. So that's why this balloon tamponade has come. So that your compression reaches up to that level. Sheila ma'am, what you...
Yeah, it
Ma'am,
was
even if
said
it doesn't go to the
that
fundus, after
if
packing,
you
the
want to
uterus
pack,
and the
no,
vagina,
if you
bleeding
want to pack,
stops.
Sheila ma'am, kindly comment on uterine packing.
Use
if
balloon
you want to
tamponade
pack,
instead
it
of...
should be 6 meter long. No, it was 6 inches broad and 6 meter long was the earlier usage. I mean, the uterus can accommodate so much. And the problem with packing is if there is a space left in between, again, there will be collection and it won't allow. Now they also came up with a hemostatic pack, that is Silox, which I have seen in most of the FIGO conferences, but now Silox also, and in fact, the company has stopped manufacturing now. In fact, I have few samples with me, and they had approached me in India also that they would like to come, but when WHO guideline came, they just stopped.
Thank you, ma'am. Thank you, Sheila ma'am. Saroj ma'am. Referral. So how we do refer? So now you have you are working at periphery, and how would you refer a case of PPH? How would you refer to the tertiary center?
So if ours is not a tertiary center and patient
ma'am.
is bleeding, then if we have NASG garment and we feel that the patient is going into shock, it is always better to apply an NASG garment, counsel the attendants, tell them that we have tried our best and she needs further management, maybe some operative procedure for which we have to send her to another hospital, arrange for an ambulance, call for the higher center, talk to the consultant out there, see if there is a bed empty, then maintaining all the vitals of the patient, whatever necessary. Suppose you are putting the UBT catheter, so let the catheter be there, do not remove it, or send one of your attendant along with one of your staff along with the patient so that she monitors the patient while she is being transferred. In
Yes,
between,
Babita ma'am.
if oxygen is needed, that has to be given. IV line needs to be maintained, Foley's catheter. Like a patient should never be, no time attendant should feel that they have been left alone or
Yes,
they have
very
been
correct, Babita ma'am.
simply.
So we have to send the patient with oxygen, IV fluids, any mechanical
And
compression,
most
any mechanical
important is
UBT,
document. We
NSD.
should document
Yeah,
every
Collagen
move of ours.
accompanying
Yes.
trained staff is very important to look after the IV fluid and all the medications and documentation of medication and other treatment given. Yes, very, very correct, Babita ma'am. So referral, this is the referral protocol to the higher center. Just one last case, a case of primary gravida delivered by instrumental vaginal delivery followed by PPH. Resident informed about cervical tear, repaired by the resident, bleeding stopped, but patient vitals not improved. On examination, a boggy mass in one fornix, uterus deviated to one side, no external bleeding. What is the diagnosis and management?
Broad ligament hematoma, I think.
Management, ma'am? Any of the panel?
Management,
Like
maintaining the vitals, and patient has to be operated and internal iliac artery ligation to be done. because we will not be able to find the source of bleeding in this patient now.
Yes.
It is a kind of supralevator
So it's a
hematoma.
case of traumatic PPH, and most probably the cervical tear had extended upwards to form a supralevator hematoma. The risk factors are primary gravida, instrumental delivery, prolonged second stage labor, and macrosomia. So management is resuscitation, ultrasound. You have to ultrasound facilities available. Do a bedside ultrasound to locate the hematoma and check the vitals. If patient is deteriorating, we may have to take her for laparotomy. We can ligate, if visible, ligate the bleeding vessels, and if not visible, we may have to go internal iliac ligation of that side. So, Saroj ma'am?
So 1 minute,
your comment?
Kanchan, 1 minute. Here comes the role of packing, like damage control resuscitation. Okay, that is, suppose if you are not able to find the bleeder, sometimes everything gets retracted and you may not find the bleeder. So you can just pack where there is a bleeding and leave the pack in situ. Okay, now if even like we have, just a minute, we have seen that umbrella pack also, that is anyway at the vault. But if inside the abdomen, if there is any oozing like broad ligamenta, we can just pack, leave it, and can be removed after 24 hours. So that is damage in surgical part, damage control resuscitation, that is also included. I think, yeah, we had that recently, complex cesarean section workshop.
Shobha Gudi did that lecture.
Yeah, Shobha Gudi did
One thing
that.
what I want to just say that this PPH we have discussed about normal delivery, but many times at the time of cesarean also PPH is faced by all of us. So the internal ligation is good, but maybe it is difficult. So all those who are practicing at smaller places, at least every one of you should learn doing uterine artery ligation nicely. And that is very simple. And many of the cases are controlled by that only. If it is atonic PPH, definitely brace sutures or V-linch will be better. But many times it may be the both you have to use V-linch suture as well as uterine artery ligation. So you should not be afraid of that ureter ban jayega. Just do the exteriorization. Ask your assistant to give traction, and so that the uterus is given traction to the opposite side. Then the ureter falls a little bit away. And just take the entire bunch of the vessels, uterine artery, vein, as well as a part of myometrium, and ligate. So if both sided it is ligated, it gives a very good control at the first step. If we require, then we can ligate both sides, or if even the ovarian can be ligated. But this is very simple because internal iliac artery, although it is very good, but many of those who are not practicing it routinely, it may found it difficult at that time. जब बहुत PPH हो गया उस समय तो वैसे ही हाथ पैर फूल गए तो internal iliac अपने आप में मिलना it may be a difficulty. So these simple procedures, every one of us should practice in routine cases many times.
One more thing,
Yes,
we can just do aortic compression. At least the bleeding, the field will become clear.
Yes.
Take a wet mop and directly compress the aorta during cesarean. Even normal vaginal delivery also, in EMOT also, we talk about aortic compression. So at least your field will be clear and you will have a view, and then you can ligate the vessels and control. Because main purpose is control the bleeding, okay? Arrest the bleeding, yeah.
Yes, yes, ma'am. Yes, thank you so much, ma'am. Thank you, Sheila ma'am and Saroj ma'am, for the great input. So, take-home message is correct anemia in pregnancy, MTSL with a quality assured oxytocic agent, and objectively measured blood loss more than 300 ml with any abnormal hemodynamic signs. It is a established case of PPH, and PPH care bundle should be included. First response is emotive, and refractory PPH care bundle, 2 compression and 2 devices. And if patient is not controlled, vitals are not stable, not responding, then we have to escalate it to surgical management of postpartum hemorrhage, which include compression suture, revascularization, and obstetric hysterectomy. So this is I'm thankful to all the learned panelists. And of course, we are running late, so we have to close it here now. And I'm thankful to Saroj ma'am and Sheila ma'am for all the great inputs. And these are my references. So thank you so very much. Thank you.
Thank you, Kanchan ma'am. Thank you, ICOG team, for making us a part of it.
Sheila ma'am.
For being with
Yeah,
us.
ma'am, thank you so much. Saroj ma'am, thank you so much.
All
It's a
the
great
panelists were very much learned. मतलब बहुत सब all of you were full of knowledge and full of confidence. So बहुत अच्छा, and Kanchan, you have done very nice.
Thank you, ma'am, for giving us this opportunity.
Hi, Meera. Hi, Meera. Seeing you after a long time.
मैम पीपीएच के बारे में जितना भी पढ़ लें, शीला मैम ने हाथ से सिखाया है यूट्राइन आर्टरी कैसे करो, बीलिंस कैसे लगाओ, बट वंस यू सी द वेसल्स pouring in front of you, everything goes, blank. Shock index अपना ही हो जाता है.
Ma'am, can I share one thing, ma'am?
Yes.
Yes. Ma'am, recently I landed into PPH and the patient has just vaginally delivered a baby. And I couldn't just control it despite everything, AMTSL, everything we did, carbetocin, oxytocin, everything. But I just only didn't use SR cannula. I just pulled the cervix to one side and I blindly applied vaginal clamp from below, that hysterectomy clamp. And it really stopped the bleeding on both the sides. I applied and I bagged everything. Like miraculously, I just escaped. I was also saved and the patient was also saved that day.
I know we have. See, we are using Dr. Piley's vaginal clamps. The first
Yes,
time
ma'am.
when I used it, I did not have, so I used the long arteries.
Yes, ma'am.
Or
Long
you
artery I
have
used.
those intestinal clamps. Intestinal clamps you have,
Yes, ma'am. Yes,
That
ma'am.
also can be used from below. And
Below.
yeah, and one more thing I wanted to add, like massive blood loss we talk about. I must share with you that we are all talking about mortality in UP. I'm doing maternal death review in Karnataka. Now, in recommendations, we have made fibrinogen injection available in every district hospital.
Oh, yes, ma'am.
Okay, because the blood products are not available. They have only blood storage facility. आप private में रहो, government में रहो, आपको छोटे गांव में नहीं मिलेगा. So if you have fibrinogen and you know it is a massive hemorrhage, at least you can give fibrinogen. She will not go
into DS.
The triad of DIC. And you can shift and save her. So Andhra also I gave a recommended, and now I'm so happy to know that recently even we did it with Andhra. Every government hospital has fibrinogen. Every government institute has fibrinogen. So Madam Dr. Saroj Singh, आप भी देखिए, सोचिए, सबसे बात कीजिए NHN से और DD से MCH mainly, and try to bring it. Okay, yeah.
And also SR cannula also should be at every PHC and CSC, ma'am.
Yes. Thank you, ma'am. So I think it's time for official vote of
Good
thanks.
job,
And
Kanchan. Good job. Good job.
Thank you, ma'am.
Excellent presentation, ma'am.
Thank you so much, ma'am.
So
And
I extend my
yeah.
Yeah, thank you, Dr. Kanchan. I extend my gratitude to our chief guests for today, Dr. Bhaskar Pal sir and Dr. Sheila Mane ma'am, and pranam to gurus, our chairpersons, Dr. Sadhna Gupta ma'am, Dr. Narendra Malhotra sir, Dr. Preeti Kumar ma'am, Dr. Kiran Pandey ma'am, and Dr. Pratik Tambe sir. I extend my dhanyavad to conveners and co-conveners, Dr. Kanchan Prasad madam and Dr. Saroj Singh ma'am, for being our margdakshaks, and Shat Naman to speakers for today's session. It was very enlightening. Dr. Anupama Upadhyay madam, Dr. Shikha Seth ma'am, and Dr. Kanchan Sharma madam. And koti dhanyavad to chairpersons of various sessions, Dr. Rajni Pachauri madam, Dr. Ritika Agrawal ma'am, Dr. Latika Agrawal ma'am, Dr. Meenal Jain, Dr. Seema Mehrotra ji, Dr. Renu Tandon ma'am, Dr. Veena Gupta ma'am, Dr. Deepti Chaturvedi madam, and Dr. Amrita Chaurasia ma'am. And I extend my thanks to Dr. Kanchan Prasad madam for conducting excellent panel discussion, Dr. Kiran Pandey madam and Dr. Saroj Singh ma'am, and of course our excellent panelist, Dr. Anita Nath madam, Dr. Meera Laktatkia madam, Dr. Preeti, Dr. Sonam, Dr. Ramneet, Dr. Mona, and last but not the least, my co-MOC, Dr. Upma Jaiswal madam, whom I got to know that she did the schooling from same school as I am.
Yeah.
This webinar. This is how Dr. Kanchan.
Dr. Kanchan played a
Friendship Day
role
celebrate
in
kar do abhi.
uniting us.
Swastika.
Yes, ma'am.
Friendship
It
Day
was
celebration.
Yeah.
yes, ma'am. Surely.
Schoolmates.
Yes,
Jab
yes,
we
ma'am.
met. Jab we
Yes.
met.
Jab we
Yes.
met. And I would also like to thank Corona Remedies for the technical support and making all this possible. So thank you once again. Good night, everyone.